água e fiz também papel para mim. Depois como me apagaram, apanharam madeira verde aí. Vai ver.
Or leave it maybe underneath, so it's, yeah.
Where's that water? Oh, that's nice. Well,
Yeah.
can I have one now
Yeah.
in case I get any asthma? There, posh. Hey.
We're going to start dead on 8 o'clock.
Yeah.
It's a shame that it's so early because you don't really get an audience, and half of the the audience are my own nerd team.
And I think that
It's really unfair, to be honest with you.
conference fatigue, and they intend to go to the 8 o'clock on the third day, but they don't.
I think it's really unfair that
You think we should start later?
yeah, I think that it's really, really unfair that you pay the registration fee, you do the work, contribution, and then I'm just saying that it's really unfair that it's at 8 o'clock, and we've got this audience with respect that
We've got our own crowd.
Yeah, I have a feeling that
who've
people will be straggling in on the third conference.
but it's not, I mean, if you think about the fees, conference fees, and you obviously want an audience. You don't want. But an 8 o'clock start on the last day is really, really unusual. No,
But I
will.
want to make sure everybody gets their 15 minutes at least.
Yeah. It's just. No, I don't think we'll finish early. Everybody's got the videos. Yeah. I hope I just keep to 15 minutes. Fingers crossed.
Welcome, everybody. Please have a seat. We'll go ahead and get started right on time, so all the speakers have their allotted time to speak. Welcome to the third and final day of ICIC 2025. I'm Bennett Davis. I'm one of the small handful of senior associates for IFIC in the United States. I'm from the University of Arizona, and I'll be introducing people. Our first two speakers are Nazreen Ali and Martha Roberts. Go ahead.
Good morning, everyone. Thank you so much for making it here for this early start. We really do appreciate this. So I'm Nazreen Ali, a Professor of Public Health Equality at the University of Bedfordshire, and also the Programme Lead for the TLC Workforce Research Programme. It's really exciting for me today to be here because I'm sharing the stage with my colleague Martha Roberts, who is Chief People Officer for Bedford, Luton and Milton Keynes BLMK Integrated Care Board, or ICB. So the focus of today's presentation is going to be sort of around two questions, really. How outreach and how research, outreach and applied theatre can drive workforce or change in workforce development, and how the CTOP initiative can make an impact in the BLMK ICB. But before I go into what CTOP is, I want to give you a little bit of context about the Talk, Listen, Change approach and the Workforce Research Programme. This slide here shows you the projects in the programme, and the programme sits within the Bedford Luton Milton Keynes Integrated Care System Research and Innovation Hub, which is situated within the Institute for Health Research at the University of Bedfordshire. We've got 10 current projects, and the programme aims to address health inequalities by developing a diverse and resilient workforce that's capable of providing inclusive care. And these projects loosely follow the student cycle, so making choices about courses and careers, preparing for university, enhancing student experience and qualifications, and importantly, developing resilience through professional life experiences. The programme is underpinned by the TLC, the Talk, Listen, Change, or TLC ethnographic approach. And we've used this to design, deliver, and evaluate these projects. And this approach really privileges voice and lived experience, and it recognises the complexity of community and ensures that we represent ethnic, age, gender, linguistic, national and social class differences. And importantly, we include the lesser heard voices or the easy to ignore voices. So what this means in reality is that we're as specific as possible, engaging with our communities and recognising ethno-national, religious, linguistic differences, and particularly communities within communities, so that we avoid any generalisation or homogenising of experience. So our approach captures people who have no English or poor English language fluency and are unlikely to engage with services due to sort of cultural or religious reasons. So back to CTOP. CTOP is the largest project within the programme. It's a culturally competent outreach intervention which has been developed through research and co-designed with people from diverse backgrounds in Luton, Bedford and Milton Keynes, which are 3 towns in Luton. So why CTOP? Why is it important? Well, we know that increasing the diversity of the health and social care workforce has been shown to improve patient care quality, enhance patient adherence to medical regimes and self-care regimes, and improve health outcomes. But we also know that there are certain groups that remain underrepresented in our health and social care workforce, and we need to ensure that our workforce represents the communities it serves. So CTOP is addressing this underrepresentation because this is a key to creating an inclusive, effective and equitable healthcare system. So CTOP aims to build trust between underserved communities and systems, to support equitable access to courses and careers in health and social care, and to contribute to inclusive practices in the BLMK ICS, which Martha's going to tell you a little bit more about shortly. So how does CTOP work then? So we've co-designed the intervention with our partners. I'm going to tell you a little bit more about that shortly. We've carried out outreach and engagement with local communities, and we're embedding the learning from CTOP within our ICB practices. So co-designing the intervention with partners, I've said it's a culturally competent intervention, but what does that actually mean in this context? So our engagement was culturally competent because we recruited and trained researchers from our local communities. Our facilitators were from our local communities who spoke the community vernacular. And even our poster people, so the design, the development of our posters, which are there at the bottom of that screen, were they were representing people from our BLMK community. We engaged with nearly 130 organisations in BLMK. I won't read out the slide, but you can see the breakdown there. We also invited our schools in BLMK to the events that we held at the University of Bedfordshire. We carried out 15 young people's focus groups, which was 92 participants during July 2023 and September 2023. We had 2 schools events, so that's 150 pupils from 10 schools. We had 3 community events, one in Bedford, one in Luton, and one in Milton Keynes. But importantly, you know, we engaged with over 300 attendees across those 3 events. The outreach and engagement with local communities and schools, what did it actually involve? So our attendees participated in interactive activities, including healthcare quizzes, storytelling sessions, featuring people from diverse backgrounds, and our students toured the University of Bedfordshire's sort of state-of-the-art new simulation suite and library, amongst other things. We've done a evaluation of our all activity, all events. A realist evaluation approach has been used, but for the purposes of today's presentation, I just wanted to show you a short video which really prioritizes or, you know, sort of reflects what was happening during CTOP from, you know, using the voices of those people who attended. I'm just going to show you 2 minutes of this.
Not only addresses local training issues and giving possibility to local members of the community to create a diverse workplace, it also approaches the issue of training and finding suitable, diverse workers within the healthcare system. And it's not taking the easy option out, it is looking at it holistically. So rather than bringing in skilled workers from third world countries and emerging economies, it's decided to run a program to train and give opportunities to local people from the community.
Hosting an event like this reaches out to the wider community. Sometimes the community is forgotten in the, out there. You have people supporting children in schools, in health centres, but not really in the community. So this event is filling that gap.
I think young people have been able to ask questions, relevant questions, that are really mattered to them. And so they've been able to get answers from the panel. So that's, to me, I see that as an achievement.
Our community doesn't actually know that there are so many different roles. I think someone mentioned about 300 different roles, which I didn't even know about.
One of the things I've been really impressed by here is the diversity in the community. And there's lots of inequalities in healthcare here. So actually to educate people in that, to reach out to communities that find it difficult to access healthcare is important, I think, and particularly amongst young people.
I've come with lots of students really not sure about what they want to do. Some of them really lack motivation with their studies, and to see those kinds of students come in and be really, really excited about what they're participating in and actually starting to think about what they want to do later on, it's been really nice to see, and I can guarantee that a few of the girls that are here today will definitely be influential women in the sector. I feel like
I'm going to stop it there. One of the highlights of CTOP was a live performance of the CTOP play. We developed this with a theatre company based in London called Comola Collective, who took the 15 focus group discussions and turned them into a script for a play, for a live performance. The process was hugely complex. We had sort of nearly 6 to 8 months of development workshops, co-designing with young people and community, and the research team to develop the actual CTOP play. It used storytelling at its heart to share findings, the voices of young people, and I want to show you a short clip that sort of summarizes the audience perceptions of the play, but also the play itself. My name's Nazreen Ali. I'm a Professor of Public Health Equality at the University of Bedfordshire. In 2015, we received funding from Health Education England to look at widening participation for South Asian young people into nursing and midwifery. We then got further funding in 2022 to commission Kamola Collective to help us turn the second iteration of the research into a theatre production. We're trying to encourage young people into health and social care courses and careers to ensure that we have a diverse workforce which meets the needs of our increasingly super diverse population. The CTOP play is inspired by focus group discussions with young people across Bedford, Luton and Milton Keynes. It's about the challenges faced by young people when trying to choose careers in health and social care, and also to signpost them to the routes they need to take.
In the play, they were talking about the three lead characters making an informal promise to all do the same course. I never really thought of that peer pressure of doing the same things.
What we've done is used theatre to bring those stories to life so that we can privilege lived experience.
The BAME community have gone as far as they could, but alternative to degrees, the apprenticeship, I don't think it is out there as much.
The more the workforce reflects the population, the better the clinical outcomes.
Our future aspiration is to take the play and the conversation around it to schools.
I learned about if you give up, just stand up and try again.
I'm trying to show young people that you've got choices, hence the title of the play. You don't need to fear the failure if you don't get your first choice. CTOP's been making change, and some key highlights from our evaluation that about 26% of pupils attending CTOP were actually from neighbourhoods where the fewest people enter higher education. Based on deprivation indicators, 50% of our population, our pupils attending, were classified as disadvantaged. We raised knowledge, perceptions and status of health and social care courses and careers. And participants said that they raised their aspirations, as you've seen in those videos. We were effective in attracting underrepresented groups, young people and career switchers, to consider courses and careers in health and social care. We haven't really got time to discuss this slide in detail, so I'm going to hand over to my colleague Martha, where we move from co-design, who's going to talk about how we move from co-design to co-production. And here, the distinction is, I'm making that distinction between co-production and co-design, where co-designing an initiative positions those participants' voices and experience at the centre, and co-production emphasises the implementation and delivery of those solutions.
Thank you, Nazreen, and hello, everybody. So, Martha Roberts, Chief People Officer for the Bedfordshire, Luton and Milton Keynes Integrated Care Board, and we are truly blessed to work in a partnership across our area, particularly with our university colleagues, University of Bedfordshire, with our research arrangements. So very pleased to be here today. We have 4 unitary authorities, a classic arrangement of provision of healthcare, and a really great voluntary and community sector of a population about 1 million odd, 45,000 health and care staff. So a really big impact in the economy on our employment of people into solid jobs with good terms and conditions, and we're really clear about the economic benefit of the public sector in reducing people working and living in poverty as well. So really important to us to be part of all the work that you've seen so far. What we will be doing with this, so wonderful to have really robust research evidence, is to catch people younger. So my team work across our system in all our schools and further education colleges, so that's kind of coming up to sort of 16 places where people are making choice points about what's possible for them and seeing themselves as being able to work in spaces where they might not identify or have felt welcome in previous generations in those workforces. So we will be taking this work with Professor Ali and her team into a second phase of implementation, working across our system, our Health and Care Academy, and all the people that we talk to around apprenticeship strategies and all that good work to make sure that when we're talking to people in our schools, they understand that the 350 odd careers just in the National Health Service, you know, digital tech, all of that is available to them, and they can see their future in that space, as well as, you know, the doctor, nurses, classic roles that people see in health and care. And we've done some amazing work around working and recruiting in areas in a way that is bespoke to that community, so that we can recruit and make our services and our jobs welcoming to people, and we've won some national awards for it, so it continues that tone. I'm conscious that we're running out of time, but we'd love to come back and tell you how we've done in a couple of years when we've taken this research into action and implemented it into our system and seen that change across our patch. But thank you, and congratulations to Professor Ali and the team for the award they won last night.
Thank you very much. That was wonderful. And yes, we want to hear what about your results. Next up, Ala Dayak from Pécs, I think in Hungary.
Good morning, everyone. So I'm Ala. I'm from Lebanon. I'm a registered nurse. I've been working in the healthcare industry for around 10 years. I'm a quality improvement specialist and currently pursuing my PhD in Hungary. How can I navigate through? So we all know how it started. Decades ago, doctors usually know better what the patient needs. So they provide care based on their perspective without taking into consideration what the actual patient need and what are their values. So this is a paternalistic approach, and it usually provide care to patient. And then came the patient-centered approach, where actually care was provided to the patient based on his values and perspectives. And here we cannot define quality without actually taking into consideration the patient expectation within the healthcare system design. And here we're gonna perform, care is being provided for the patient. And recently, the innovative approach of patient partnership, where we believe that the patient and the public are underutilized resources with valuable experimental knowledge, and it's utilized, it's based on this partnership based on trust, equity, and mutual understanding. And here we are providing care for the patient. The reason I'm discussing actually this approach is to share a brief story that I've encountered several years ago in 2018. So I'm a registered nurse and neonatal intensive care nurse. I previously saw the engagement of the parents and the progress the newborn actually face when their parents are really engaged in their care. So the more the parents are engaged and supported and educated, the more the care is, the more the prognosis of the babies were. So we were in the class back in 2018, and we were discussing different tracer and audit approaches. And back then, we were discussing the teams that should be involved in the patient tracer. And then I was like, why should we trace a patient in the care? Rather, why shouldn't we engage the patient into the audit team and let them observe and data collect system pitfalls along with the healthcare team? So back then, I saw the shock among my colleagues, and I saw some of them laugh, and I think we've all been there. Some of them actually called me crazy, like how would you let the patient know our system pitfalls? How would you let them recognize that we are in some sort of system failure? And how would you expect them later on to visit our healthcare system and communicate with this organization, and they know that we have system pitfall? So this drives me really to invest my time, change the mindset, and pursue, and then apply for this patient partnership approach into our community. And we were actually able to launch the first patient partnership back in Lebanon in 2022. And we had official committee meetings with the patient and the public later on. And we won an international award based on our project successful indicators. So the reason I'm sharing this story is to navigate through the different patient roles that the patient actually can be successful into the engagement of the design of the healthcare system. So starting from the care plan improvement, involvement in the care plan, shared decision making, consultation, support group for the cancer patient, and this is a project actually we worked on and it was very successful. Focus group quality improvement, and staff recruitment and training. We're actually now involving the patient into the recruitment of the staff and actually training for them to gain skills that are needed for their practice in the hospital. And we're currently aiming to engage the patient into the public education and definitely later on engage the patient in the clinical research. So as a quality expert, we all know that quality is a continuous process. We start by the plan and implement this plan, corrective action, and we continuously monitor and improve and evaluate our progress. One of those approaches or tools used to perform those quality evaluation is the patient tracer and the audit performed. So we identify the problem, determine the causes, root cause analysis, provide suggested solutions, select appropriate changes, carry out those changes, and then re-examine and re-evaluate. So in this project, we actually engage the patient in the step before the co-design, which is the co-diagnose, where we believe that the patient is able to diagnose the healthcare system along with the healthcare professionals. So our project started by the preparation, definitely. We coordinated with the patient affairs department at the hospital. We developed an audit tool, and it was a comprehensive, holistic audit tool that was based on the accreditation standards. We've trained those partners into the usage of this tool, similar to any healthcare professional quality expert. And based on this volunteer and the willingness to participate, we selected those patient partners from the hospital and also from the public. And we've trained, we came up to recruit 50 patient partners. We've trained them along 3 months, over a period of 3 months. But the training was actually involved the topic of quality improvement, patient partnership concept definitely, and those audit tools that we need. And we've launched the program around 6 months. Those patients were actually involved in the audit team in the hospital, and we performed audit for the inpatient and outpatient departments, similar to any accreditation preparation program within the hospital. And for the evaluation, we utilized the patient and public engagement evaluation tool, which is a standardized holistic tool, and we performed data collection through the qualitative interviews. So our sample, more than half of our sample were females, and their mean age was around 53 years old, and most of the participants were actually patients themselves. The reason that I'm displaying the socioeconomic characteristics of our sample is to prove that the patient partners can actually has actually low economic level and low education level, and it's not significantly related to their education level or involvement in the healthcare industry. Rather, every patient has the right to be empowered and involved in the care. So for the results, we've covered several departments within the hospital. The inpatient audit score that the patient collected was around 106 out of 120 score. And for the outpatient department, they scored 69 points out of 84. And as I said, patient partners' characteristics were not significantly different among the audit score. And the patient partner experience for the evaluation of the program was 54 out of 65 points. For the patient and public engagement evaluation tool actually has 4 pillars. One of them, the communication, the ability to share the views and perspective, the impact and influence of the whole engagement project, and the overall satisfaction with the engagement. And as you can see, all of the percentages were above 90, which indicates the success of this project and the motivation that patient partners had along with this project. So as I said before, the tool was based on the accreditation standards, and the priority focus areas were mainly the patient and family rights, which are the main foundation for quality improvement, the communication of the healthcare professionals, the ethics within the hospital related to informed consent and confidentiality, the discharge process, patient safety, continuity of care, and plan of care, and infection. Even we've involved the patient into the audit of the infection prevention and control processes within the hospital. And as you can see, percentage were high. The most of the scored percentage were to the patient and family rights, both in the inpatient and the outpatient departments. So the key learnings for this successful partnership initiative that I would like to share based on our individual experience is mainly the preparation. We have to change our mindset. This project was planned back in 2018 until 2025. So change really takes time. We need to start by changing our mindset to accept that patients are really empowered. They should know. They should know in order to reach a point that we are actually providing the care based on their values without safety errors and without system malfunction. We should select those patient partners and train them equally similar to any healthcare professional training program. We should have a good structure and good communication channels within the project. Coordination is a key, and management support definitely is the key player for this successful project. And here I'm referring to the resources and funding allocation along with the authority and authorized for those patients to be empowered. We should utilize evidence-based strategies involved in the usage of the quality tools and the design of the tools themselves. This project, actually, we designed the tool with the patient involved rather than the quality professionals by their own. And here we should empower the patients, integrate the services, and definitely engage the staff. Because we've faced the challenges with the staff accepting the new patient role. So here it's very important to change the mindset of our staff, let them be aware about the new role of the patient, empower them, train them positively, and reinforce on the needed communication very much among those. Evaluation, and we continuously evaluate and get feedback from the patient partners and also from the staff in order to enhance our overall project and outcomes. So here I would like to share some quotes from the patients who were involved in the previous projects. Some of the patients actually said, finally, we were able to be heard. Like they were missing this point in their care. And some of the patients felt very respected, cared for, and felt they have a role in their community. They were able to be socially acceptable within their community, and thus we all know the effect of the social health overall, the healthcare outcome and the prognosis of the patient. So co-designing with the patient and co-diagnosing with the patient partners actually is an innovative approach that is very much superior to the previous traditional and conventional audit processes that are usually performed by the healthcare staff alone. And thank you.
Next up, we have, right behind me, Carmen Schneider. Thank you.
Thank you for everyone being here on the early post-gala dinner session. Each year, the Australian Institute for Health and Welfare in Australia publishes a very useful flowchart demonstrating the health expenditure in Australia, where it originates from and where it lands. And I find this flowchart to be one of the very best arguments for why we need better integrated care in Australia. What we see on the left side of the chart is sources of funds our federal government, our state governments, individuals and private health insurers and some other non-government funding, which flows in complicated ways to our hospitals, primary healthcare providers, referred specialist providers and non-referred specialist providers. And what we find is that this funding also aligns with quite different governance structures for the different elements of our healthcare system. And people that are working and trying to deliver service in those systems end up with different priorities when it comes to integrated care. So people working in our hospital sector are really keen to be able to reduce burden, to be able to reduce unavoidable admissions, reduce costly ED visits, while people working in primary care clinics are really keen to ensure that they have a viable operational model with their fee-for-service funding and want to have good referral options for their patients. Whereas those that are sitting in those in-between kinds of services are really keen to ensure that patients can get access to them as well as have stable funding, considering they have a much more complicated mix of the way that they get their income. So considering this complex mix of funding and funding streams, there's long been a strong interest in having integrated care projects in Australia and integrated care policies that bring this together. And we've had a long string of what we would call integrated care policies and initiatives that are listed here, from coordinated care trials to infrastructure projects that bring people all together in one place, innovators, commissioning projects, urgent care clinics, super clinics, polyclinics, healthcare homes trials, integrated care and commissioning. Many of these have been reported on over the last 25 years at this very conference. And what we're interested in the project today is the way that we have been translating these integrated care policy initiatives and bringing them to the local level. What we have here is the result of these different funding streams, two different maps of the local level authorities that end up being the doers of integrated care initiatives. On the one side, we have the hospital networks, and on the other side, we have primary care networks, as they are in the state of New South Wales, where I'm from. And you may notice that the borders of these different regions actually do not overlap, which is something that we might come back to a little bit later on. So we're interested here in this nexus between having integrated care policies and then actually having to implement these, and ultimately they go down to local levels. And that goes through what we are operationalising as competitive contractual devolution. So this might be familiar to the way that integrated care is actually brought into regions in your home countries as well. It's competitive in that if a local region wants to be an implementing region of an integrated care policy region, they'll need to put up their hand and they'll need to apply for those resources and have a plan of how to spend them. And they may or may not be successful in being a chosen region to run one of these integrated care initiatives, particularly in the early phase. They are contractual in that funding and support is then tied with expectations from the often state authority or national authority, with expectations of outputs, outcomes and activities, KPIs, as it were. But there's also devolution in that as many decisions as possible and the actual implementation, the nitty-gritty of how to actually do it, is devolved and left to local implementation. So this has a strong rationale: experimentation, pilot and testing, what works, good opportunities for learning and optimisation. It lowers the risk for the funding body because all the risk of actually doing it gets shifted, and there's adaptation to local needs. But there are also challenges with this in that there is a central vision but a need to implement locally. And the idea is usually we're implementing locally because you know your local needs and you'll be able to do what you need in that local area. So that means there's a tension between fidelity and flexibility, and this kind of contracting is usually also cyclical. So you'll have one that's called value-based care, and then you'll have the next one that's called patient-centred commissioning, and you'll have the next one which is called something slightly different again. And there are a lot of unknowns about local context. So we wanted to ask what elements of local context impact on the implementation of integrated care initiatives under this competitive contractual devolution, and how is this articulated in local planning and decision making, and how does the dynamic between local context and competitive contractual devolution impact on our overall trajectory of integrated care improvement and initiatives in New South Wales. So the test case that we were able to look at is one of those initiatives called Collaborative Commissioning. It's an initiative of New South Wales Health, so at the state level, but it was a bit unique in that it requested that the hospital networks get together with the primary care networks, and they were going to get joint funding together to implement local care pathways very similar to many that have been presented at this conference, but they would have joint responsibility for that planning. So once again, under the usual system, if those two regions could get together, they put in an expression of interest, they went through a joint development phase to convince the state authority that, yep, they were ready to go, and then went into an implementation phase. As part of our broader evaluation, our group had the task of doing formative evaluations of these then locally implemented regions. So that involved developing the theory of change for each of the regions in how they were going to implement the initiative. And it was through the comparative analysis of that theory of change to the overarching theory of change that we were able to then address our questions for this particular meta sub-study. So we undertook theory of change interviews and workshops. We were articulating the rationale, assumptions and logic of each of the region to be able to then undertake the comparative analysis. We had 2 urban regions that were included, 2 rural regions that were included. One decided to address geriatric outreach, another decided to address diabetes care, another 2 decided to address rehabilitation following COPD, as well as chronic heart failure diagnoses. So what elements of local context were impacting on the implementation of the health system initiatives? So first of all, relationships that were already existing in those local regions had a really large impact. So that included what relationships existed between the hospital and primary care authorities. That also included the relationships that already existed or could be formed with other service providers in the region. But there was also a large impact on the relationship between that region, and really coming down to the very personal level, and the state authorities who were effectively commissioning out the work or distributing the funds through these contractual devolution. Resources were also absolutely critical and key. Available workforce to be able to then implement and work together and create a local theory of change, and the locality and the availability of the different types of service providers. So that comes down to the organisational level of service providers. Also, the different structures in the local regions, and by that I mean the various different patterns of living, so people that live, and of working within that region. And that includes the ability of the various different stakeholders and players regionally to tap into different income streams. So there was a big difference as to whether the implementing region was fully reliant on the income from this particular initiative, or whether they were already had multiple different income streams that they were able to potentially build on. And finally, the level of experience of the local regions on doing this kind of contractual devolution work cycle after cycle. The more positive experiences a region had of having success and then being able to build this initiative onto something that they'd previously done or recently previously done before, built their capacity. So how did this articulate into local planning and our decision making? There was quite variation in the extent to which the local regions were able to form their own governance substructures. In some cases, it could be chief executives, highest level, got together and had joint committees. In others, that got devolved even further down into some implementation working groups. Sometimes they could tap into existing committees, but the extent to which there was buy-in from the highest levels to say this is something that we're doing continually really made an impact on whether they were able to actually follow through with their theory of change. It all those factors also determined the way that they were then able to use the funds and build the different incentives to get service providers to come together in terms of engaging them and having to provide those incentives, paying per patient, for example, or using already embedded workforce, rostering people differently, or even having subcontracts below the contract for additional service providers. There was also a lot of variation in the way that the local implementation needed to adjust to the willingness of existing providers to engage. So questions around whether providers were willing to enrol patients or mark patients in the system as enrolled in this particular initiative, or whether service providers were very much, this is yet another initiative on top of another initiative, and we're willing to adjust our workflow and our work practices, but we're not going to join in and enrol patients specifically. That makes it really harder for people like us who then evaluate these kinds of initiatives if we don't have patients enrolled, and it's harder to track them. Another key decision that was then influenced by all of these different structures, but particularly those relationships and what kind of cohort would they want to target, and whether those decisions were made really truly based on local need, which was the initial overarching goal or vision of the initiative, or whether those decisions were actually made more in response to those targets or KPIs that the state level policymaker had set. And there was a real tension between that, and we often found that at the start of this particular initiative, which has run for 4 years, there was a lot of enthusiasm to target cohorts that they were identified as where there were real gaps locally, but over time this switched to change, in one region actually changing the target cohort, but in other regions shifting the activities somewhat so that they could respond specifically to some of those KPIs. There was less flexibility as time went on. And we also found that as time went on, there was a shift in which partner played which role within this initiative. And ultimately, the partner that ended up playing a greater role in this initiative, so ended up being sort of the safety net or the gap filler to make sure that the initiative worked, was the hospital network. And it's no coincidence that it's the hospital network which usually receives the funding from this particular initiative policy level. There were also other decisions that were made amongst some of the other regions to focus on certain context clusters that they had, so filling sort of service deserts or focusing on cultural safety. So how does this then impact on the broader trajectory of integrated care initiatives? So this, like many of the initiatives, certainly served to build an understanding of what local systems actually look like. Going through all of this process of having something devolve down to the local region, having partners get together, means that there is far greater awareness of who plays what role and what service gaps there are, and also where it's difficult for patients to move from one part of the system to another part of the system. It also leads to having broader offerings for those target cohorts. So there is certainly ability to have success in expanding at least the service offering, although that has often come down to the hospital network filling that gap by effectively expanding their outpatient scope of services. But what we do find is that there is often retrofitting over time in these initiatives as things tend to flick back towards those initial conditions of the contract, which in the early stages are very much your decision at the local regions. At the later stages, when we're thinking about understanding whether the initiative and funding will continue, goes back to some of those initial KPIs. And so often people working at the local regions feel like there are real shifting goalposts, a period of freedom, and then contextual challenges with implementation, and then coming back to having to make sure that you get some quick wins on the board in order to be able to keep going or to be able to roll over to the next initiative. So local context is a really strong key as a determinant of implementation, but the source and mode of articulating integrated care policies is a determining driver to probably improve, but in the end still reinforce the status quo, depending on who it is and the channel through which the integrated care initiative funding comes. So true local integration is ultimately going to require some financial and governance independence to overcome this status quo and system drivers of fragmentation. Thank you.
Thank you very much, Dr. Snyder. Peter Gong is up fourth. Here he comes. Thank you.
Hello. Oh, thank you. Okay, well, good morning, everyone. My name is Peter Gong. I am from Toronto, Canada, and I'm a project manager at the East Toronto Family Practice Network. So this is day 3 of the conference. In the past couple of days, we've heard a lot of mentions about integration, collaboration, partnership, teamwork, which is all great concepts, but we also recognize that sometimes it is just really difficult to work with other people, which is why it's necessary for us to have an effective governance structure to ensure that there's good partnership in our projects. So today, I would like to share our experience at implementing a governance structure for a multi-partnered AI scribe initiative. Before we dive into the key concepts, I would like to first provide a brief background of my organization, as well as the AI that we're trying to implement. So, how does this work? Okay. In 2019, the government of Ontario introduced the Ontario Health Teams, or OHTs for short. There are 58 of these OHTs across the province. The goal of the OHTs is to, so first of all, the OHTs brings together local healthcare partners, such as the hospitals, primary care, social and community service providers, into one integrated and local team. The goal of the OHTs is to deliver a more integrated and connected care at the local level. The East Toronto Health Partners is one of these 58 OHTs, and it has more than 100 of these local health and community partners. And one of its key partners is the East Toronto Family Practice Network, which is the organization that I belong to. We are a non-for-profit organization that represents the voices of over 200 primary care providers. And our goal is to connect the primary care within our OHT. And due to the importance of primary care in our healthcare system, it's actually mandated for every OHT to have a family practice network. So for the purposes of today's conversation, you can think of OHTs as representing and having access to a network of primary care providers within its catchment area. One of the key goals of my organization is to provide or facilitate access to digital solutions for primary care providers, which brings us back to our AI Scribe initiative. And so our AI initiative aims to reduce the administrative burden that's faced by many primary care providers. Studies have shown that right now, family physicians spend almost half of their clinical hours interacting with a computer instead of a patient, and this leads to an increase in clinician burnout and career dissatisfaction. For the AI Scribes, for this project, we are trying to introduce the AI Scribes into primary care. The AI Scribes can transcribe clinician and patient conversations in real time and help to reduce charting time by a significant margin. And so that was a brief background on the OHTs, Ontario Health Teams, and the AI while we're implementing the AI Scribe initiative. For the remainder of the presentation, I would like to dive into details of how we set up our governance structure for this partnership. Okay, so my organization, together with 6 other health service providers, was given a grant to implement AI into primary care. And so here you can see a breakdown of our partnership. First, we're working with an academic institution. Their focus is on the research and evaluation of the effectiveness of the AI Scribe tool to reduce administrative burden. Next, we are working with 4 Ontario Health Teams. Their role is primarily to connect with their primary care providers and promote the use of the AI Scribe to explain why it is useful, and ultimately be responsible for providing the AI Scribes into the hands of the physicians, clinicians that needs it the most. We're working with AI Scribe vendor. Of course, this is the company that's providing the AI Scribes for our initiative. And finally, we're working with an organization that specializes in change management. Their role is to help the clinicians to adopt and implement the AI Scribes into their day-to-day workflow. So here you can see that we're working with a diverse cohort of partners. I want to draw your attention to the OHTs in the middle, the 4 partners in the middle there. They are equal partners in this initiative, which means that there is an absence of a clear decision-making hierarchy. Right? So this was one of our first challenges, is to ensure that we develop a fair and equitable decision-making process. Second, we are also working with limited resources, and so in our case, this is the number of AI Scribe licenses, and so the OHT partners, the 4 partners, are expected to share these AI licenses to then eventually distribute within their own respective primary care networks. Our OHT partners also differs in the number of primary care providers they represent. Some are significantly larger than others in terms of their membership. And so overall, this creates a potential conflict of interest within our partners as they compete for limited resources. So this is our governance model. Wow, this slide is not interesting at all. But as you can see, it's quite straightforward. This is the governance structure that we have implemented for our initiative. It's quite simple, as you can see. So starting at the top, you have the leadership level, follow that by the operations, which oversees the various different working groups. So one of the first things that we did, and this might be obvious, but it's still important nonetheless, is that we communicated very clearly at the onset of the initiative that we were committed to ensure that this would be a collaborative effort amongst our partners. And so we're committed to create a space where all the partners can come together and be involved in the decision-making process. So instead of taking a top-to-bottom or command and control approach, we wanted to ensure that all the partners would have a say in the decision-making process. As a result, all the partners are represented in the leadership and operations level of the project. For our 4 OHT partners, specifically, we wanted to ensure that there will be equal representation, and so regardless of the size or membership of their respective organizations. The second thing we did was that we treated our 2 vendor partners, and so that's the AI Scribe a vendor, and the organization that provides change management services. We made a choice to treat those two vendor partners as collaborators rather than just service providers. And the benefit of this for the project teams is that by working closely with these vendor partners, we were able to leverage their leadership's experiences and expertise outside of what we purchased, the services that we're purchasing. This also made the vendor partners felt like they were integral parts of partners of the initiative, which they absolutely were in this case. And I'll dive into the details of that integration right now. So starting at the leadership level, this is where we are committed to a shared decision-making process. This is co-led by our academic and vendor partner, the vendor that provides change management services. There are 3 rationales for this decision. First, because the OHT partners are ultimately responsible for delivering the AI Scribe licenses to their respective primary care networks, the OHT partners would be the only partners with voting power in our collaboration. And second, by having these non-voting partners, so the academic partner and the vendor partner, in positions of leadership, this ensures that there will be a balance of power among the voting members. And lastly, as mentioned, leveraging the vendor experience and where we can foster a greater buy-in and accountability even for these non-voting partners. Next, moving down to the operations table. And so at this level, this is co-led by the project manager, so that's myself, and our vendor partner. And again, the setup for the voting structure is the same as the leadership one, where only the 4 OHT partners would have voting power. Here, I serve a dual purpose of being the project manager for the overall initiative, as well as a representative of one of the OHT partners. So in closing, I'll share some risks associated with our approach. So first, even though there was benefits of leveraging the non-voting partners, so the academic partner and the vendor partners, as our leadership, our co-leads, we also relied on them having a strong buy-in into the project to be effective leaders. A few ways this risk was mitigated. First, it was a voluntary commitment. And second, by the weight of the position. And third, by the fact that the individuals occupying these leadership roles were themselves primary care physicians, so they have lived experience of the administrative burden that we're trying to address here. And the second risk, as mentioned, I serve a dual role in this project where I am the project manager for the overall initiative, but also as a representative of one of the voting partners. And so in this case, this setup relied on having a deep level of trust among the partners, but also on me to recognize this trust and to live up to it by being transparent and candid in my presentations, and by being open to feedback and to ensure that there's equal opportunity for collaboration among the partners. And in closing, first of all, this is still an ongoing project. We're just crossed year 1 of the year 2 project. But so far, this governance structure that we've set up has been effective at managing our partnership so far. There's a sense of shared accountability, which ensure that all the partners, whether they are voting or non-voting, contributes to the success of the program. Thank you.
This concludes our session. In this venue, it can be a little difficult to get questions. So what I'm going to suggest is that people use the app to message, if you would like to message the presenters. I've already sent 2 messages for the questions off myself. We do have some time. We have a few minutes, so there are 2 microphones in there, and I can't quite see if anyone is at them, but if you have a question, maybe we have time for one. Okay, well, thanks, everybody. Thanks for the session. We'll conclude the session, and the presenters down here, if you'd like to come please.
Good morning.
We've got the plenary now.
Isto é para passar, não é? Portanto, aqui, para trazer aqui e a coisa para apontar aqui.
Vai fazer aqui no menu.
stealing another water. Present, present. Sorry. Oh, bless you. Oh, thank you so much.
No, you close your eyes. Let's see that
did
one.
I?
Yeah, take another one.
Okay, shall I take my glasses off and then I can smile a bit better? And would you take one of the four of us if we... Yeah, thank you. Yeah, honestly, I'm not a vain creature, so well, that was lovely. Thank you so much. Yeah, it was the kid.
Maybe if we stand here. I think we can stand here. Yeah, speak here. I think maybe here.
name is Diogo Almeida. I'm a family doctor and I'm the coordinator of o ICF Descobertas. So, o ICF Descobertas was founded in 2009, and since 2012 we integrate a model of organization that gives us more autonomy in what has to do with the way we provide care to our patients. We offer care to more than 16,000 patients from 0 to 102 years old. Here we have consultations of family planning, child and maternal health, acute disease, chronic disease management as well, and home visits. In our building work daily 9 family doctors, 5 residents, 8 nurses, 6 admin staff, and we also work with a psychologist and a social worker. We work with a concept that is a family team, that is a team that is composed by a family doctor and the nurse. So every family have someone they can recognize as my doctor, my nurse, and I think that this is very important. And one of the things, one of the major advantages that I see in this way that we provide care is that we know the patients, we know their families, and we know the resources that we have in the community, which makes it easier for us to help patients and to make them feel more secure and more supported by us. So, prevention is one of the gold standards of primary care, and here, considering that we know the family and even more, we know the environment where they live, we can have much more clues about the way we can help them getting healthier. One of the things is that we see families like a microsystem where we can do just one small change that will interact with all the elements of that family and can be very, very useful, because with one action we can help a lot of people, especially when it comes to, for example, changing some behaviors. Some elements of that family can support the others, so it's like a feedback model that we can use in these situations. It's very interesting because people usually say my doctor, my nurse, so they see us like part of the family, and sometimes they say it to us, and we are very delighted to hear this kind of things. Because we are really close to the patients, we are in the community. Some patients just have to cross the street and they are here in our healthcare center. So they are very close to us, and they find it easier to ask some questions, some advice, and it helps a lot because we know them, they know us. And it makes it easier because when they come to the doctor, they don't have to explain it for one more time, because it's going to be the same doctor, the same nurse. So we are a community and we are in the community. I think that the key word is share. We should share our experience with our colleagues, with the other doctors, with the nurses. We should share our needs and our expertise with the community, and we share also our experience and our doubts with the hospital care, for example. I would say that share is the key word.
Bom dia e bem-vindo. Benvindo. So you won't believe this, but just to say that improperly, I have had support from the IT people up there, Miguel itself, and Flor, the taxi driver last night, and I still cannot say it properly. I'll keep trying. So my name is Edelweiss Aldasoro. I am a senior researcher at the International Foundation of Integrated Care, and I'm here with Miguel Costa Lopez, who has been a huge part of organizing this event. He's part of PAFIC, and he's also president of the local health units in the Alto Alentejo.
Perfect.
Well done. So this is the last plenary, and it's going to be a little bit of a challenge because I would like we all reflect together, how can we factor this sustainable goal we are going to discuss now, which is about how can we make our habitats, we can call it ecosystem, we can call it in a different way, our world, a better place and a sustainable place for all. And if we go back to the principles we've been discussing these days, we have heard that responding to crisis at individual basis is not working. It hasn't worked. It has bring us to this fragmented care. And we've been discussing all these days about how can we make that better. We have mentioned person-centered care. We have mentioned that it has to be coordinated. It has to have continuity. That from reactive, we have to go through to proactive. That we have to consider promotion and prevention, treatment and care, but not only response to crisis. So if we take that, I would say that we have used kind of like augmented lenses. We have focused on health and care, and we have taken an angle of integrated care. But then we are challenged by the subject we are going to discuss today, which is sustainability. So that does make us open our angle a little bit, change our lenses, and try to think, what is our role and our responsibility from our health and care perspectives, just to make this much more sustainable? And all these principles that we have talked about in individual basis, do we actually take them to the organizational component out of health and care? And if the answer is yes, and I invite you to reflect on your own in your own context, how, with whom? And I think our panelists are going to give us some guidance from their own experiences, but I invite you to reflect from your own context and experience. I just would like to bring one final comment here. At the center of my town, it's written very big in my language, Basque, it says, Zirelako gara, garelako izango dira. Meaning that we are because they were, and they will be because we are. Meaning that all together, can we reflect a little bit if we can ensure that we all are and that they will be, and how? So, Miguel, your turn.
Thank you, Edelweiss. You say it perfectly. Bem-vindo. Bom dia a todos to this last plenary session. When we start defining the major theme of this conference, we discuss with ICIC if it's not a good opportunity to include integration of care in terms of a common goal that we all have in terms of sustainable development goals that was set in 2015 by the United Nations. And the answer was yes. So this session, this plenary, will be focused on how we, as players and as also community members, can play a major role by implementing integration of care can achieve also sustainable development goals. So, and without further ado, because you are not here to hear us, but to hear our speakers and our commentators that bring us an experience from the field, it's a huge pleasure to introduce to you Professor Luis Campos. He is a medical doctor and also the founder and the president of the Portuguese Council for Health and the Environment. And for the last years, he works hard and also with a huge team, with broader stakeholders to put on the agenda the importance of environmental sustainability in healthcare and broader in the role of all players from communities, from municipalities, and for the industry, particularly from pharma industry and medical devices industry. And He also bring us several decades of experience and contributions to the development of the Portuguese healthcare system. He is also a fellow of the European Federation of Internal Medicine and also an honorary fellow of the American College of Physicians. And also Luis Campos is also a visual art with more than 17 exhibitions in Portugal and worldwide. So thank you so much, Professor, for accepting our invitation, and the floor is yours.
Thank you. So, good morning, everyone. Thank you and congratulations to PAFIC and ICIC for the organization of this fantastic Congress. And thanks for inviting me and to make a presentation that you will like the least to hear in this Congress. That is integrated care against climate change. And this is my disclosures. I am father of 3 children, 2 of them are here, and I believe that we cannot ensure our well-being compromising the future of the next generations that are the generations of our children and of our grandchildren. And we are not speaking about the future. We are speaking about the present. Valencia, Australia, Amazon, India, Europe. Every day, climate catastrophes are on the screen of our televisions at our homes. The main environmental determinants of health are evolving according to the most pessimistic scenarios. First, the overpopulation, the climate change, the degradation of ecosystems and pollution, the loss of biodiversity, and depletion of natural resources. In reality, it took us 300,000 years to reach a world population of 1 billion, what succeeded in 1,803. And only 220 years to reach 8 billion people, what happened in 15th of November 2022. And since 1970, our ecological footprint has exceeded the Earth's rate of regeneration. 2044 was the hottest year ever recorded, with average temperatures above 1.5 degrees. We must remember that 1.5 degrees was the limit established in the Paris Agreement to 2100. And even maybe it was the coldest year of the rest of our lives. Besides that, there are tipping points, points of no return. There are 25 tipping points. If they succeed, we have no provision of the intensity, of the speed of what is going after. And the closest tipping point is the Atlantic Ocean circulation change. Climate change is due to the increased greenhouse gases emissions. And the world would need to halve these emissions by 2030 in order to limit global warming to 1.5 degrees in this century. But the health system that is so important to answer to the risk of new pandemic or a climate catastrophe is also responsible for these emissions. Globally, 4.4% of the emissions come from the healthcare sector. In Portugal, it's even worse, it's 4.8%. Globally, 9 out of 10 people breathe air containing high levels of pollutants exceeding the WHO guideline limits. And pollution, not only air pollution, but all the pollution, is now the biggest risk factor for global mortality. Biodiversity is declining. 150 species become extinct every day. There are 1 million species in danger of extinction. Environmental changes are the biggest threat to the health of populations in the coming decades. Every year, environmental factors are responsible for 1 in 4 total global deaths. And this impact is systemic, which are the most impacted diseases: cardiovascular diseases, respiratory diseases, allergies, cancer, the vector-transmitted diseases, zoonosis, the diseases related with quality of food and quality of water, the direct effects of the extreme heat, and also the mental diseases, particularly a new disease that is called eco-anxiety, that is the anguish of the new generations in face of their future. This is the pandemic threat timeline from 1997 to 2023. I was director of the emergency department in Lisbon in 2003 when we had to face the SARS pandemic. And we prepared all the hospital to face this pandemic. Most of the changes were profited to the new pandemic, to COVID-19. But in reality, since then, we have had 1, 2, or 3 pandemic threats per year. So COVID-19 was an announced pandemic, and the risk of pandemics is even greater each year because of deforestation. Heat-related mortality incidence. As you see, this is the graphic of the heat-related mortality incidence in Europe from 2000 to 2020, the annual death per million per decade. And you can see that Portugal and Spain are the most vulnerable countries in Europe. Public literacy and education of health professions in relation to environmental changes are very low. This is a survey that we did in conjunction with other organizations to 800 people in Portugal, where we concluded that although only 1% of the population believes that climate change will not have an impact on their quality of life, only a quarter feel really informed about this issue. This is another survey that we did to 348 doctors of the 5 specialties that prescribe inhalers. And in this survey, we concluded that only 52% of doctors are aware of the environmental footprint of inhalers. So we need to improve the resilience of the health system to respond to the increased risk of climate disasters or a new pandemic. And the COVID-19 pandemic uncovered the deficiencies of the health systems. And it's my belief that most countries haven't learned their lesson. And in many countries, we are in a worse condition now than we were in 2020 to respond to a new pandemic. But if this was bad in countries with national services and universal access and free access to the public, to health, this was even worse where private medicine is prevalent. For instance, in the United States, black people die 2.2 times more than white people. Integrated care is not only necessary to meet these challenges, but it is indispensable. This is the most complex challenge that we face for the future. And integrated solutions are key to dealing with complexity. Integrated care can have a huge impact on the interrelationship between health and environment, on disease prevention and promoting healthy and environmentally friendly behaviors, increasing quality of care and rationalization of resources, promoting environmentally sustainable organizational changes, align health, environment, urban planning, and social protection policies, promoting climate health literacy and technical training for professionals, and increasing the resilience of the health system. And I will give some examples of this impact. Promoting, for instance, the way as we have food, it has impact in this ecological footprint. Promoting plant-based diets and active mobility reduces the greenhouse gases emissions, but also has health co-benefits. For instance, the beef, 1 kilo of beef is responsible for almost 100 kilos of emissions of carbon dioxide. So next time that you eat a beef, think about this. Improving quality means more environmental sustainability, avoidable admissions, decreasing over-screening, over-diagnosing, over-treatment, increasing quality is good for patients and is good for environment. I bring you here one example. This is a graphic of OECD with the number of cities CO2. So if we reduce CO2, this rate, we can improve environment. The other case is the proximity medicine. The proximity medicine reduces healthcare carbon footprint. I bring here the Mafra case. Mafra is a municipality not far from Lisbon, and the distance to the people in Mafra is only primary care in Mafra. To get consultations, specialized consultations, they have to come to Lisbon, is 80 kilometers round trip, or to Torres Vedras, that is 73 kilometers round trip. Consultations, exams, surgery, and so on. So if each of the 86 inhabitants of the municipality has 5 consultations and 5 examinations every year in the NHS, this represents 65 million kilometers traveled, which could only be offset by planting 688,000 trees to capture the carbon dioxide from the atmosphere. However, if they have an insurance, They have a private clinic that is a very integrated care center because it has the primary care physician, 26 specialties, all the exams, and they don't have to travel from Mafra. The question is why the NHS doesn't do like this. Case management reduces healthcare carbon footprint. This is a case management program that in Centro Hospitalar Lisboa Ocidental that I promoted in my department. On 1 year, we reduced by 48% the number of emergency visits and by 41% of the hospital admissions. If we think about all the high users of the emergency, that was the target of this program, an annual 41% annual reduction in the number of hospitalizations in the emergency high users would avoid 34,000 hospitalizations and emissions of more than 15,000 tons of carbon dioxide. Telemedicine reduces healthcare carbon footprint. This is a graphic showing the number of monthly teleconsultations between 2017 and 2025, where you can see that this number improved after the pandemic. The increase in this number of teleconsultations allowed the reduction of the greenhouse gases emissions of 652 tons of carbon dioxide. Connection with pharmacies is very important. In Portugal, we started to do the seasonal vaccination in the pharmacies. And this change in the 2022-2023, 69% of the people traveled by taxi or car, and when the vaccination started to be done in the pharmacy, only 43% need to do that. And this change, the carbon footprint reduced from 1,253 tons of carbon dioxide to 739 tons. But also the connection with municipalities. Municipalities play an important role in implementing climate change adaptation measures, promoting environmentally friendly behaviors, and protecting the most vulnerable populations. For instance, this is 6 methods to cool the city. And the municipality is very important to the protection of the most vulnerable people. And this is a map that was not distributed in this Congress, that is urban heat islands in Lisbon, where you can see that the place where you are having this Congress was chosen because it's one of the most fresh places in Lisbon. And integrated care is also important to build a climate-resilient health system. We need emergency plans with coordinated management, network operation at each level of care, integration of different levels, articulation of health with environment, civil protection and social assistance, information and communication systems with interoperability, and adequate and sufficient human resources. And my last topic is this. Health professionals must take a leadership in the fight against climate change and environmental degradation. We have to say that climate change is a public health emergency. And WHO is saying this. Before Baku COP in last year, the director of WHO demanded urgent integration of health in climate negotiations ahead of COP29. It was the only second topic cope with a day dedicated to health. And what we feel is that the environmental policies doesn't take into account health, and political health and policy health has not taken into account environment. And besides, we are trusted professions. Healthcare professions are trusted by the community. This is a survey done by Ipsos in 31 countries where it was asked which was the profession where you trust more. And 58% said that were doctors. But it's not only doctors, it's doctors, nurses, all the health professions. In comparison, only 14% told that it were politicians. So we have to use our voice to say that we don't face a problem of ecologists or young radicals, but a problem that affects all of us. But we have to be careful, because combining fear with feeling of impotence paralyzes action. And the Portuguese Society of Internal Medicine in 2017, when I was president of this society, was the first internal medicine society in the world to make an appeal to greater engagement of health professions in this fight. In 2022, we managed to put together the 45 societies included in the European Federation of Internal Medicine to make a similar appeal. And last year, for the first time, I think, in science, we put together all the countries that speak Spanish with all the countries that speak Portuguese, 29 countries also appealing to greater engagement of healthcare professionals in this fight. And these were the reasons why I created the Portuguese Council for Health and Environment that was announced in October 19, 2022 in Gulbenkian Foundation. And what I felt is that to face a complex problem, we cannot have monoprofessional associations, medical associations, nurse associations. We need the diversity of the associations related with health. So the objective was to create a collaborative network that encompasses all the diversity of health-related organizations to minimize the impact on population health environmental changes, reduce the environmental footprint of the healthcare sector, promote awareness, literacy, and education. It's shocking to see how is the biggest challenge that we face and determines the health of the populations and how the universities don't put this in the pre-graduate curricula to foster research in this area and to increase the resilience of the healthcare system. And in 2.5 years, we became the most transversal health alliance in Portugal. We have health associations, professional councils, 23 scientific societies, 10 universities, pharmaceutical laboratories, research, private health groups, hospitals, patients associations, municipalities, waste companies, consultancy companies, insurance companies, and technological companies like Google. And we promoted the first international course on health and environment that will have a second edition this year. Last year it was in English. This year will be in Portuguese, more dedicated to African countries that speak Portuguese and also to Brazil, and you are invited to register in this course. We are working with the societies to make recommendations to decrease the ecological footprint in certain sectors of the healthcare sector. We started with inhalers, but we'll go to anesthetic gases, hemodialysis, laboratories of clinical pathology, surgical room. We founded the Portuguese Observatory of Health and Environment that published the first report in January. It has 277 pages with 80 authors and is available in our website, cpscia.pt. And we made the first National Congress on Health and Environment in Lisbon this year in February with 1,000 participants of more than 50 professions. And we are trying this year to stimulate the collaboration between our members. One of the examples is this national campaign for blue wrap collection and recycling. This blue wrap, as you know, is a plastic that wraps the surgical boxes in the surgical room, and in Portugal is considered contaminated material. So we achieved special authorizations from the agency, Portuguese Environmental Agency and Directorate General of Health to authorize the recycling of this material. We joined 9 hospitals. We started to collect this material 1 ton per month with help of any NHO social assistant, with help of transport company. We have an NHO of social reintegration that recycles and construct clothes and other materials from this plastic. And also we have a plastic company that is profiting this plastic. So this is an example of the opportunities that rise when we put different organizations collaborating. And I will finish with the legend of the hummingbird. And the legend that came from America say, one day there was a huge fire in the forest. All the terrified animals watched helplessly as the disaster unfolded. Only the little hummingbird was active, picking up a few drops of water with his beak to throw into the fire. After some time, the armadillo, irritated by all the ridiculous commotion, said to him, "Hummingbird, are you crazy? It's not with these drops of water that you are going to put out the fire." And Hummingbird replied, "I know, but I'm doing my part." So my appeal is each of you think what is the part that you can do. Thank you.
So, thank you so much, Luis. We are going to welcome Sonia Roshnik at the moment. She's going to join us virtually. Sonia, are you there? Welcome. Sonia is an executive director of the Geneva Sustainability Center. She's got a huge experience in sustainability in healthcare. She's going to talk a little bit why making healthcare sustainable matters. Sonia, the mic is yours.
Thank you so much. I'm delighted to be with you today. Just sorry that I'm not in the room with you, but I'm really here to try and build on what Luis has said and describe a little bit more about why this is so important to healthcare and how healthcare can respond. It is actually, I get quite fearful hearing about all the stories about climate change, and I need to know how I can really contribute. And healthcare is very much part of the solution. So I'm going to tell you a little bit about what it means.
Sonia,
yes?
Apologies for interrupting you. You are in a presentation mode. I don't know if you could just switch it to the, I mean, we can see.
Okay, I'll switch it to, is this better?
Yes, thank you so much. Apologies.
Okay, No, that's great. Thank you. So I'd also like to talk a little bit about the different points of entry that you can look at, and also how some examples like Luis highlighted as well, and then really focus a little bit at the end about how we can scale up and use levers to make this a larger scale movement that we should all be working towards. So the Geneva Sustainability Centre is part of the International Hospital Federation that has got lots of different hospital associations in over 70 countries that are part of. And what's interesting is about 4 years ago, they decided that sustainability was one of the things that hospital leaders needed help with or wanted support to know how to integrate this into the operations of their hospitals. And that's why we were set up, is really very much to support the leadership of hospitals on this journey, and to acknowledge that actually we need to address climate change as an integral part of healthcare delivery in every aspect of everything we do in healthcare. And you'll see that by doing that, we can all contribute in so many different ways. Now, we know, in some ways, I would like to sort of say that the main problem is not climate change. The main problem is that we don't know really how much we should be acting on this or what we should be doing about it. So we've tried to describe what we think low carbon, equitable and resilient healthcare might be about. And you can see here that it is very much about enhancing the quality of care, understanding the determinants of health, building resilience, working collaboratively, and developing a committed leadership around this. And I guess this might resonate a lot with all of you who are working in integrated care. And of course, you know, it goes without saying that you cannot consider our individual health without considering the health of the community and our wider planetary health systems. So all of these elements are interrelated. And the thing that I find most encouraging about all this is that it really means that if we're wanting to act and take, as Luis suggested, play our part, there are so many different points of entry where you can get started. So if we want to develop sustainable, resilient, healthy people and places, we can reduce environmental impacts in all sorts of different ways, and we've heard some examples today. We can reduce inequalities because we know that that actually doesn't help the health of populations, and we can reduce the burden of disease. But we can also work on encouraging independence and well-being. We can work on building on our social assets and all the resources we've got in our human capital, and we can also enhance our environment. And all of those elements will contribute to a better world for all of us and better health. Now, one of the main barriers that I always hear as to why people don't want to act in this space is because they think it's going to cost too much. But we know that for one thing is that if we act now, it will cost less than acting later. The sooner we get onto this, the better. But also we know that the health benefits really outweigh the costs. So there is something about getting our financial calculations in the right place to make sure that we're doing, we're investing in better health for future generations, like Edelweiss said earlier. Now, from my perspective, one of the things that we really need to try and do is to integrate this in the very notion of what quality of care is about. There's no point in seeing sustainability as something that you do on the side at the end of the day or lunchtime when you've got a little bit of a moment and you're looking for volunteers to do. It should be a pillar of quality of care, and just as much as safety, patient experience, and other elements are. We can also look at value of care if we're trying to, often the equation is looking at the outcomes for patients based on the costs that are put into the equation. And, in reality, we need to widen that equation to make sure that we take into account not just patient experience, the clinical effectiveness and patient safety, but also what this means for wider populations. Personally, I really don't want to be given care
if I know that it's going to impact on somebody else's health elsewhere. I do think that as patients, we also have a responsibility to make sure that the care that we are given is good for everyone, and it can be done in that way. It's just a matter of shifting that lens, just like Edavai said earlier. And then if you look at the costs, sorry, I've jumped one, then we need to make sure that we don't just consider the financial costs, as most often we do, but consider what the environmental and social costs of what we're doing are, so that we end up with a much better way of describing what is good value care. And just to give you an example here of why it matters so much, this is the carbon footprint of an Australian healthcare system. And if you looked at some of the elements of the system that are harmful or low value care compared to effective care, you can see that there's close to 40% that is actually probably not effective or useful. So there are a lot of things that we could be doing differently that would contribute immensely to reducing the environmental impacts of the care that we deliver. So, when I started looking more closely at, the sort of principles around sustainability in healthcare and integrated care, I can only come across alignment and similarities. There's a similar, there's shared values and vision, there's a focus on population health and the local context. People need to be partners in their care. We're talking about resilient communities, being more effective in our use of the workforce, having system-wide governance and leadership, digital solutions, aligned payment systems, and so on. So everything that we're doing in terms of promoting integrated care, preventative care, is going in the right direction. And I'm just going to give you some examples. We've heard some already today, but this is the University Hospitals of Geneva, who've really decided to focus a lot of attention on how they're going to integrate environmental impacts, but also equality and diversity and sustainability in the products that they use in every aspect of the way they deliver healthcare. So, and that is very much a corporately driven approach, not just a professional by professional approach. The NHS, where I worked for a while, has also developed a roadmap to say this is how you could get down to zero emissions. And what is very clear from this roadmap is it is not sufficient to have, net zero buildings, net zero travel, and net zero products. The very way we deliver care, the models of care, the way we try and focus on prevention, the way we bring in innovation into the ways we can deliver better healthcare matter hugely as well. And we will, that's an invitation to us as health professionals to really say, how can we deliver the best health for the population with the least impact on our resources? We mentioned inhalers today as well, and the reason why I'm bringing this up is that it's not just a question of information. We've got here on the right-hand side some information that was developed by the National Institute of Clinical Excellence in the UK to highlight the different environmental impact of different inhalers. But in reality, it's a lot more complex than that if you think of it as a systems perspective. And, we know there's other alternatives available to the way you get the inhaler product into lungs. We know that it's not entirely clinically dependent because the prescriptions around Europe vary between 30% and 70%. And we know that we need to work, the relationship between patients and doctors has an influence on this, and getting the right diagnosis too. But the thing that really shocked me and disappointed me, but it just highlights how system-orientated we need to be, is that the real shift started happening in the UK when the NHS England, the organisation that sort of oversees the implementation of healthcare, started incentivising GPs with money to start shifting their prescribing practice. And that is the point where pharmaceutical industries started to think, now they're serious. So information is not enough. We need to also find the right leverage points in the system to really make a difference. We've talked about different health professionals and how they can contribute to this. I'm an occupational therapist by training. The World Federation of Occupational Therapists came up quite early with the sort of what does this mean for me as a practitioner and how can we all contribute to some of these shifts in our own clinical practice. But if we want to scale up all of this change, we've, with the International Hospital Federation and the Joint Commission International, developed some standards for hospital accreditation. And for the first time this year, they are now a compulsory part of hospital accreditation. That means not only are hospitals going to be accredited for patient safety, for the quality of care that they deliver in different areas, their digital solutions, but they also have to demonstrate that they are taking very seriously these aspects within the work that they're doing. There's some measurable elements that are part of that. So it's beginning to integrate it into the very licensing and accreditation of hospitals. There is also now a certification program for those hospitals who want to demonstrate that further progress, or those health systems that want to demonstrate further progress. And the concept is really that you can be showcased and you can evidence the progress you're making. The key element around this is that you need to be demonstrating improvement. We know that this is a long journey that we're all going to be on, and the key point is to get started and then show year-on-year improvement. And as part of that, there is a tool to try and demonstrate all the different aspects that need to be considered as part of accreditation or certification. And it's not just reducing environmental impact, it's very much also about trying to address the social determinants of health and look at the health vulnerability assessments in your community. So just like Luis highlighted heat maps in Lisbon, you can understand a lot more what's happening in your community, how your hospital and your integrated healthcare system needs to respond to that. And then there's something about how we can support through the right kind of governance processes, the ongoing need to tackle this issue. And I would like to sort of get closer to saying that this is, or our view at the International Hospital Federation and the Geneva Sustainability Center, this is very much a leadership competency. We are all leaders in our own right, whatever we're doing within healthcare. And, the world is shifting fast. There's a number of challenges, and we've seen them all highlighted to us today. But when the IHF revisited its leadership competencies, it's introduced some extra elements around how do we deal with preparedness and crisis management, how do we deal with digital technologies, compassionate leadership, but also sustainability leadership and organizational resilience and advocacy, as we've heard before. And I would like to suggest that if we see this as a competency rather than a set of we don't need hospital leaders or health professionals. I think we don't need them to become climate scientists. We need them to understand how to integrate this into our roles and the way we lead our organizations. So one of the elements that we're looking at, because there are some hospitals in this world that are operating in much lower resource settings with even more challenges than maybe some of our countries. We've looked at how maybe you can try and integrate the response to the need to develop climate resilient and low carbon systems, also with the workforce capacity issues, the financing solutions, and quality of care. And in these countries where climate change is a daily occurrence, it is becoming even more urgent to find an integrated solution. So I'm hoping that we can learn from a lot of these countries and bring in some of the answers to some of the OECD countries too. So if you'd like to hear more about this, please consider the World Hospital Congress. It's in Geneva this year. There's a strong strand on sustainability. It's a great opportunity to share with other hospital associations, other leaders, other health professionals what you're doing in this world. And, you know, we're also there to help. So do get in touch with us if you'd like some more support on the journey. We're very much action-orientated, solution-orientated, and wanting to accelerate progress. And, you know, I'm also leaving you with a quote, maybe not a legend, but, you know, if you think of all the different areas that we can operate in, that we can have an influence on, you know, sustainability isn't about doing less harm, in my mind. It's about doing more good. And we need to find a way of making sure that we care for our planet, care for our patients, and care for our people. I'll leave it there and look forward to hearing the panelists and the conversation that will follow. Thank you very much.
So thank you, Sonia. Can I just invite you, we won't have time to have a lot of interaction with the audience, but can you use the app that you put your comments and have some interaction there? I'm pretty sure you all have a lot of comments and experiences. And we're going to introduce the panel now, Miguel.
Yes, let's move forward. And we'll have Chris Naylan and Neto Juniarty via streaming, I believe. And Monica, it's here with us. So, can I invite you to reflect and share with us your thoughts about if we are doing what is needed to make our health and care systems more sustainable for the future? And I will start with Chris Naylor from the UK. He's a senior fellow of the health policy think tank at the King's Fund, and he has a background in health policy and research, and is passionate about creating sustainable health and care services that are resilient for the future. So, Chris, can you share with us your thoughts about what Sonia and Luis share with us during this plenary session?
Absolutely. Thank you, Miguel, and pleasure to be with you all here this morning. And thank you to Luis and Sonia for two really excellent presentations as well. I thought I would just pick out 3 points that really landed with me from those presentations, 3 really important messages, I think. And the first is about this being an agenda for all of us. Think back to that pie chart that Sonia showed us, the 20-80 split. So 20% of the carbon impact of healthcare is about our buildings and our electricity use and our heating. The other 80% is about what goes on clinically. And what that tells us is that providing the same care in more energy efficient buildings won't be enough. We need clinical transformation, and that means we need clinical leadership. So people from across the whole workforce will need to play a part in this. The second message from the presentations for me was about needing to approach this with some urgency. So Lewis talked through some of the latest evidence from climate science, and I think what that evidence is telling us is that if we don't take sufficient action in the 2020s, then it's going to be hard or impossible to make up for lost ground in the 2030s and 2040s. So of course, health systems are dealing with a lot at the moment, we know that, but we can't wait for ideal circumstances to do this work. We need to do it now. And then the third thing is a more positive thing, hopefully, which is one of the messages that came through both presentations loud and clear, I think, is that climate change, as well as being a risk, climate change mitigation represents a real opportunity for the health sector. There's an opportunity here to improve population health, and there's an opportunity to deliver better services as well, because fundamentally sustainable healthcare means being more preventative and proactive so that we keep people well and that we avoid carbon intensive hospital activity wherever possible. It means being person-centered so that we provide the forms of care and support that offer most value to individual patients. And it means being efficient in the way that we use resources. So delivering the right care in the right place at the right time and eliminating unnecessary steps in the pathways. I think there's also an opportunity in a broader sense too. So if we look at what's going on in other sectors of the global economy at the moment, the drive for sustainability is creating a stimulus for innovation. There was a great article in the Harvard Business Review a few years ago describing sustainability as being innovation's new frontier. And I think by playing a leading part in this drive for sustainable innovation, all of us in the healthcare sector can make faster progress towards our own strategic goals as well. So I think the question that I'll sort of close my comments with is that if we accept this argument that we need to be doing healthcare in a more sustainable way, then what are the conditions we need to create to allow sustainable healthcare to grow and flourish? That's something that we're looking at in England at the moment, so that the Health Foundation and the King's Fund and the Centre for Sustainable Healthcare are working together on a research project examining the national accountability mechanisms that we need in order to drive sustainability in the healthcare system. So if that's a question that you're interested in, please do get in contact, and it'd be great to talk. But Miguel Edelweiss, I'll hand back over to you at this point. Thank you.
Thank you so much, Chris. And moving forward, please, I will give you the word, Nettie, to share with us your vision also. Let me only share that Nettie comes from Indonesia. And she's a community health nurse and associate professor in the Faculty of Nursing at the Universities of Padjadjaran. I hope I say it well, but I think I'm not. So can you share your vision?
Yeah, thank you, Miguel. You pronounced correctly. Yes. I'm Nettie from Universitas Padjadjaran, Indonesia. Thank you, Luis and Sonia, for very insightful presentation. From your presentation, I think I take 2 key points for take-home message. That public literacy and education of health professionals in relation to environmental changes are low. So if I may share my experience, I also a member of Center of Citarum River Research in Universitas Padjadjaran in Indonesia. So Citarum River is the most polluted river in Indonesia, and it caused lots of disaster. And despite all efforts to invite health professions to involve in the Center of Research, there are only 1 nurse and 1 doctor that willing to involve actively. So I think it is very important to educate health profession in relation to environmental changes, and particularly climate change, and also how to improve the environmental health. And also to improve the literacy of people in the community. I've done some research to empower people and to do the waste management, because some of Indonesian people have habit of throwing rubbish and garbage to the river, and that's why it become the most polluted river in Indonesia. So yeah, and from this study, Luis, I think you're right that people trust health professional more than other discipline, because there are multidisciplinary researchers in the research center. And yeah, to build the climate resilient health system, we need integration of different level of care, articulation of health with environment, civil protection, and social assistance, and also multidisciplinary collaboration in different level, in different government, and also involving health sectors. So they feel they have responsibility, that the environmental health, the river health are responsibility of all people in the community. And from Sonia, I'm particularly interested in the low carbon, equitable, and resilient healthcare. and also Greener Care Initiative. I think in Indonesia, for hospitals, we have stricter regulation for the Greener Initiative, but I highlight because I am a community health nurse and I work with public health centers in the community mostly. For the Greener Care Initiative, is still need big progress because one of the reason is the cost. The cost is quite expensive for community health centers or public health centers in village and rural area. So I think this is one thing that I'll try to make changes in Indonesia. And also I would like to highlight the importance of integrated care and sustainability by focusing on population health and local context because people are partners in care and we can build resilience in community. So in my other research, I try to involve empowering and engaging people to do the planning, what they think, what they want, what they will do about their society. And I think it's show better results when people are willing to involve from the beginning. We can see more sustainable results and hopefully can prevent a health impact of climate change. I think that's all my thought from Luis and Sonia's presentation. Thank you.
Thank you so much, Nettie, for joining us and share your experience and your thoughts about the necessity to improve capacity, both professionals and community. And now we move for Monica, that is here present in the auditorium. She came from Australia, long far away, and she's a health executive, and now is currently serving as chief executive at Health North Coast. So can you share the perspective of a manager about sustainability?
Thank you, Miguel, and thank you so much to Sonia and Lewis for very thought-provoking presentations. I enjoyed them very much. And look, the thing that really rings true for me is around resilience. And in Australia, we have quite a bit of evidence now that shows that resilient communities bounce back quicker when these disruptions, climate events, natural disasters, whatever you want to call them, happen. And I really think from a healthcare perspective that really does need to be one of our key focuses. But resilient communities need resilient health systems, and only integrated health systems can be resilient. So I really do concur with some of the statements from Lewis and Sonia around that, because that really does need to be our focus. And I can say from personal experience, I come from a region in the east coast of Australia. It's a subtropical region. Very beautiful region. I very much enjoy living there. But one of the downsides of our region is that we have a lot of rain, and it's actually, in some people call our region the many rivers. And the many rivers, when the many rivers flow from the rains that come, we get immense flooding in our region. And when we have our rain, the forests also grow. So when we go through droughts, we have these terrible fires. And in the last 5 years, we've had actually 6 major natural disasters in our region. 3 years ago, we had catastrophic flooding where 40,000 residents were significantly impacted and 10,000 houses were made uninhabitable. And so these types of events, when they happen, they really do have such huge disruption across the whole community. And our health system, of course, is so key to supporting communities to come back from what is absolutely very traumatic situations. And that trauma-informed lens, I think, is something that we really do need. We have in health because we're all trained in it. But a lot of the other agencies that are responsible for responding to these disasters and events, they don't necessarily have that lens. So we have a lot to offer in health in terms of building resilience and helping communities to recover from what is quite disruptive and quite traumatic events. I guess my final comments would be that we do need to also remember this is a new challenge, and I remember somebody at the beginning of the Integrated Care Conference, I think it was on Wednesday, saying that we have to remember that this work is hard because we are working against the status quo. And I think in this space, it's also very true that we have to remember this is a very new space, and that paralysis from the fear that can be quite overwhelming. So we need to not only bring a trauma-informed approach, but also compassion. Compassion for each other, compassion for our peers, and compassion for our neighbours. I certainly would observe that in the experiences that we've had in responding to these events in my region, that very much a place-based response, coupled with your national, your state governments and emergency response agencies, is one of the most effective ways to have the best response. That place-based connection, the place-based network that you have in your community, in your health system, is really, really key. So again, only integrated systems will be resilient to be able to face whatever we see in the future.
Thank you.
Thank you so much, Monica. Unfortunately, we are coming to the end of the session.
We don't have questions?
No time. We have questions. And actually, what I was going to say is that this session has felt a bit too short to me.
Yeah.
And I think we have opened more doors than we have given answers. And I would like ask Sonia and Luis maybe to finish with the final thoughts about integrated care conferences, and just talking about integrated care, sometimes it feels too big already. And we have included something that looks much bigger, and we have had this discussion during the conference, that people think, I understand where we are. What I don't know is what is the next step for me when I go back home these days. So, as big or small your role is, I don't know if Luis and Sonia, you could give kind of like some take-home message that looks feasible to do it tomorrow. So maybe, Luis, you start?
Okay. So the first message is that we have to integrate health and environment. For people, environment is an abstract thing, but when we start to say that environmental factors are killing 1 in 4 people and is affecting all of us, plastics is now a factor, a risk to atherosclerosis, for instance. So this is concrete and can be motivating. Second, before we add health in all policies, I think we should have environment in all policies. Environment in all the decisions that we make. And we need the involvement of all of us in all levels, international level, national level, organizational level, department level, individual level. Each of us can play a role in this fight. But this has to be a political priority. If not, we will have episodic initiatives in the hospitals, in the healthcare sector. We should have services at our hospitals that help the other departments to implement changes to reduce the impact, the ecological impact of the healthcare sector. We should have also recommendations, what we should do in the surgical room, what we should do in hemodialysis, what we should do in the laboratories of clinical pathology, about anesthetic gases. So we need also the involvement, as it was said already, of the clinical science, of the clinicians, of the healthcare professionals. It's not only transport, lighting, cooling system, energy system. The clinical side is very important. And we need to include the evaluation of the impact, environmental impact, in all the changes that we implement. When we implement case management, integration of care, proximity medicine, and so on, quality, improve, to include monitorization and evaluation of the environmental impact, because this is also another argument to defend the changes that we want. And this is what I think is the concluding remarks.
Thank you so much, Luis. Sonia?
So I would say if you're in a leadership role in an organization, making sure that you have a chief sustainability officer or a governance structure that means that you can tackle this journey in the long term and make sure you've got mechanisms for reporting on progress, developing an action plan, looking at a roadmap would be essential and an easy step that could get started, as you go back. If you're a healthcare professional, then I think trying to put on these new glasses, like Edelweiss had said, to look at everything that you do in a different way. We use so many products. We waste a lot. We can focus more on prevention. It's taking your caring responsibility and say, I'm embracing the caring of my environment at the same time. And there are multiple opportunities of doing it. I've just got an example of a nurse in the UK who came out of her training, started working in a ward and said, why are we using all these things in this way? I'm sure we could do it different. Luckily, the ward manager said, go ahead and find alternatives and suggest them to them. Anybody can look at anything that you're doing and start with any small step and say, hey, actually, why are we doing this like this? It doesn't have to be. And so I would encourage you to just, we don't have to become very complicated. We can substitute things. We can talk about it with our patients. There's so many different ways of doing it. So I would just encourage you to just get started. Do one thing when you go back to work. Next day you go to work. And then start from there.
Thank you so much, Sonia. Can we leave this session with an applause to the panelists and with a promise to continue the discussion? Thank you so much, everybody. I'm also conscious that this is the last time we are going to be all together in one room, even though the conference continues. Let me please thank the IT group behind this, because it has made this session really as smooth as all the conference. And Miguel, from your perspective, maybe you would like to say the final words, taking the opportunity that everybody is here.
Thank you. Thank you, Edelweiss. I think from a final conclusion from this plenary session, of course, all of us, both as citizens and healthcare professionals, wherever we are, playing a role, we must take urgent actions against climate change and these impacts. And as Sonia said, something simple can make a huge impact in our daily life and as professionals. I also like to thank, because this is our last plenary session, to thank you, ICIC, on behalf of the Portuguese Association of Integration of Care, for challenging us to bring this conference to Lisbon. It was 3 intensive days of sharing knowledge and experience and best practice. And thank you so much for being here with us for these 3 last days. And I hope that all of you take good lessons to when you return home, or if you stay for more days in Portugal. And you are always welcome to Portugal when you want. So, bom regresso a casa a todos e uma boa continuação de conferência. I would like you also to share that for us, from the Portuguese Association of Integrated Care, Yesterday was a very important day because for the first time we joined here all the Portuguese-speaking countries in a summit, and we start a new movement towards integration of care in the Portuguese-speaking countries. And next year, we'll join for the second summit in Brazil. So thank you so much for the Brazilian colleagues that accept our invitation to moving forward and work together about integration of care. Thank you so much. Muito obrigado.
Just one thing before you leave, final comments, and I'm going to circle back to what we said at the first plenary. We came here to connect, learn, and share, but the work doesn't finish here. We just continue. Like you can see some of the work we've done now, but please, during the year, we are going to continue being connected, learning and sharing together, and IFIC is going to be here to support you all, and Portugal is going to be welcome everywhere we go. So thank you so much, and see you later.
Perfect. Thank you. And then the microphones, I can use either? Yes. Do you have to turn it on? It's on already.
No, it's on. My colleague is open. Yeah. You see?
Testing, testing. Testing, testing.
Now you can talk.
Testing, testing. Okay, good. I was nervous when I'm in your place. I'm like, ah. Okay, thank you.
Thank you.
Yeah.
good morning, everyone. I hope you've had a good networking session over coffee. I'm going to pull us in to start this first breakout session of the day, and it's my very great pleasure to chair and introduce myself as Anne Hendry. I'm Director of ICIC's Country Hub in Scotland, and I'm also a chair of a local hospice in Scotland. So this topic of integrated palliative and end-of-life care is a subject that's very dear to my heart. We've got a session in 3 sections. We're going to go on a global tour, starting off with Ontario, and then moving to Latin America, and then over east towards Europe. So today I'm going to kick us off with the first presentation on hospice at home, improving palliative care access for an underserved community in northwestern Toronto. And I'm going to welcome Beatrice, Dipti and Kathleen, who are going to give us a very joined up presentation by the 3 of them who are, I think, seeing this service from slightly different lenses. So thank you, ladies.
Thank you, Anne, for this introduction. Hi, I'm Beatrice, and it's a pleasure to be here today to share our journey and our results. So I'll get us going as to why we're here. So we're going to share overview, our partnership, focus on innovation, equity, design thinking, and integrated care, and of course our outcomes and what's next. So just to set the stage, I work for acute care teaching community hospital in Northwest Toronto. And we serve a very marginalized community, highly racialized, with lots of social determinants of health that are quite challenging. And we have a really high proportion of older adults, over 80, more so than the rest of our province. And many of these people die at home or die in a hospital and die without supportive palliative care. And they wish they had it, but they don't. So if you look at our population, it's highly racialized, as I mentioned, high level of unemployment. Many people don't work, low income, doesn't really set them up for much success or supports. And many live alone, especially seniors. And then looking further, we are a primary care desert. People don't have primary care. They have high prevalence of chronic conditions, which become palliative, of course, and we've never had support. It doesn't really set them up for success or quality death experience. And many have housing and food insecurity, so our area is known to have really high material deprivation index, the highest, and that's kind of shown there on the slide. And then what do we have to offer these people when they're facing end of life? Not very much. So we're also kind of a palliative care desert. So our hospital is the Red Cross there in the middle, and then there's a hospice at the very top left corner, and one at the bottom corner, and there's nothing else. So really have nowhere to go but the acute care hospital to die. And then when people are in the hospital and they have palliative diagnosis, over 63% of them pass away in a hospital, which is again higher than a provincial average of 50%. And when people do leave our hospital and do go home, many do come back, and then they die then. So it's just a lot of death, and none of it is planned or supportive. And it's really because these people have equity-deserving needs and haven't been supported for many, many years. So we wanted to change that. So just to set you up, in Ontario, we do have universal health care, and there is home care that's universally provided, but it's very limited. And you really need implementation of private pay, you need family supports, and you need knowledge and somebody to guide you. None of these things exist in our community. So that service alone doesn't really help people. So we thought, what could we do together? What could we do better? So we created a program, Hospice at Home. How can we deliver hospice services in the home setting by integrating across the continuum with various services? So we partnered with a hospice, we partnered with community supports, and what was available free from home care to develop this program. And it's small because our funding came from foundation and donors. Our target was 30 patients for 1 year. And you saw earlier, the hospice is really far away from us. So we have a very small area that we intercept. So the patients who live in that area or clients, they become eligible to receive the service. And now Kathleen will take us through the actual program.
Thank you so much. So the Hospice at Home program, just to give you an overview, is an integrated care model that combines home care, hospice services, and community support services that align patient and caregiver goals and provides 24 access to support services. The value out of this program is that it takes what Ontario Health at Home already offers and augments it with the holistic aspect of hospice care and provides access to palliative care physicians. The integrated team approach of the Dorothy Lake Hospice Coordinator, the Dorothy Lake physician, and Ontario Health at Home Services work together to develop care plans with the patient and the caregiver to ensure that we are delivering what they want, that we are meeting their goals. And this supports a comprehensive and patient-centered approach. This is just a roadmap to our journey. So where it starts is in the acute care setting, where the person is admitted to an inpatient unit. The social worker or a team member, whether it's physician, nurse, allied professional, will identify the person as a potential candidate. From there, we reach out to Dorothy Lay and we bring in the hospice coordinator to start having conversations. Does this person meet the criteria? Does this person likely benefit from the program? From there, we do a referral on to Ontario Health at Home, and then we bring both coordinators in to speak to the family, to go over the services and what can be provided. And we also start the discussion of what are your goals, because ultimately we can give you everything that you want, but that's what we want. What do you actually want? That's the important aspect of it. Then we get to discharge, and once we discharge, they've left the acute care setting, but the beauty of this program is the hospice coordinator from Dorothy Lay acts as that liaison to continue to provide the health and community supports and be the liaison to the hospital also and between the physician to ensure this person doesn't get lost. They also lead integrated huddles with the team members and with Ontario Health at Home to ensure that everyone is on board and care plans are being altered as needed to address patient and caregiver needs. The primary aspect, as Beatrice mentioned, was equity. And when you look at the demographics that we have, the big things to point out are the vast majority of our patients referred were born outside of Canada. In terms of languages, you can see we have quite a few languages there. Well, some of them, or the majority, is English. That's a language that they can communicate in. It isn't necessarily their first language. And then we have the languages that they prefer to speak in. And then we get to household composition, where over a third of our patients live alone. The next third live in a combination of either with spouse, who themselves could be elderly or have their own health issues, or they live with spouse and family. And then we get into the availability of family caregivers, where 60%, 66% do have access, comprehensive or moderate, to family caregivers, but we do have a good portion that have minimal to no access to family caregivers. This is just a roadmap of our referrals through to transition home for our fiscal year 24-25. We did have a big uptake in Q4 as people started to become more comfortable and familiar with the program. We do have a difference between our referrals versus enrollments because things happen such as patients went to rehab, some patients were able to access PCU or hospice beds direct from hospital, and other patients unfortunately did pass away before they were able to enroll or transition home. And our patient profiles and care fund, this is also what sets our program apart. We developed 4 programs based on PPS scores and prognosis with the focus on an upstream approach to palliative care. And the goal was to help prepare, set up, and implement the psychosocial supports needed for the patient and the caregiver. We know that as a person's journey through palliative care progresses, the costs associated do increase, especially when they end up in hospital at end of life. That's probably the most expensive cost. We wanted to demonstrate that early involvement, so starting with people who had a PPS of 70 with a prognosis of 6 to 12 months, the sooner that we could start and develop the relationships, this built trust and actually supported the mitigation of ED visits, hospitalization, and supporting end of life in the patient's preferred location, whether it be hospice, home, or wherever they choose. We also know that as things progress with cost increases, we have to look at needs. We're not upfront loading. We're not providing all the services at the top. We're providing them at the back end when they might need things such as Meals on Wheels, respite care, transportation to and from appointments, hospital beds, things such as that. We do this in collaboration with patients and caregivers to ensure that what's being provided aligns with their goals. And as I mentioned, that early involvement does build that trusting relationship where patients and caregivers do start calling the 24/7 line before calling 911 to go to hospital. And when we look at enrollment by prognosis, initially we did have quite a few more at what we called P4. P4 was a PPS of less than 30, and we deemed it end of life. If you go to Q4, which would have been January to March of this past year, we had a shift. We started to have earlier referrals to the program because we did have the people that we work with in the hospital, such as our allied team, our nursing, social worker, recognize if we get people in earlier, we're not seeing them come back to hospital. And I'm going to pass it off to Dipti now.
Thank you, Kathleen. And I'm going to talk about our outcomes to date. And so we have seen outcomes across the domains of population health, patient experience, provider experience, cost, and health equity. I'm not going to talk about all of them, but I'm going to highlight a couple that are really important. So patient caregiver experience is really important, and we do surveys of our patients and their caregivers throughout the program and after the person passes away with their caregivers. So far, we're seeing 100% of our patients are reporting that they're very satisfied with the program. 80% of our caregivers feel supported. That was really important for us. There's a lot of stress on caregivers emotionally to see their loved one pass away or dying, but also to care at home. 76% of our patients died in their preferred place of death, which was either at home or in a residential hospice or palliative care unit. We also saw a reduction in costs as it relates to hospital use. 83% of the people that called our 24/7 helpline avoided a hospital emergency department visit, which then translated into less admissions, less ALC days, and cost savings for the hospital. And then on the equity front, as you saw, we are really trying to design a program that addresses the equity needs of our community. We are seeing that people are accessing the Comfort and Care Fund, which is a set of dollars associated with the various levels of care, and they're accessing things like food, meals, transportation, supplies. You can't die at home unless you have incontinence supplies, and in our current publicly funded home care system, there are very, very limited services. So again, trying to provide the things that people need to actually stay at home that they can't currently access in our current system, and we're seeing really good outcomes with that. I'm going to share a quick story because you can see all the data, but to actually have an experience of a patient. So this is Mr. T. He's 79. He's got metastatic colon cancer. When we met him in September, when we enrolled him in the program, he had a prognosis of about less than 6 months. He had 2 ED visits and hospitalizations prior to enrolling in the program. When he was enrolled in the program, his biggest concern wasn't his cancer. It was actually that he was really, really lonely. He was divorced and didn't get out of his home, didn't see people, and through the support of our hospice coordinator who was able to work with him around his needs, he's now attending our day program and he is connecting with people. His caregiver feels more supported. He gets support for his medical needs with our physician that goes into the home. So he's had only 1 ED visits in the last 9 months, which was appropriate, and he has said he's less lonely and much happier. His daughter is thrilled. She says she's so happy to see her dad happy, connected with people, and she is so grateful to the program because, as she says, it's made a difficult time more manageable. In terms of early lessons learned, I'm going to skip that because I'm going to talk about it in our how we're moving forward. So as we move forward, we're wanting to complete our evaluation. We are extending our program through in-kind resources of our organizations for one more year. We're going to enroll another 30 patients, and we're going to complete our comprehensive evaluation. The goal then is to advocate for ongoing funding to sustain the program, but also to expand the program. And then we're using the lessons learned, and a couple of key lessons learned that Kathleen had highlighted as well is, the earlier we get involved in palliative care, and those of us in palliative care know that, the earlier we get involved, the better the outcomes are for individuals and their families. In Ontario today, only about 50% of people access any palliative care before they die, and of that 50%, about 60% access that care in the last 2 months of life, so too late. And so thinking about earlier involvement, we're looking at a palliative care clinic that we can create to see people earlier and support them. We also saw that a big gap, and our lesson learned was that there aren't enough hospice beds. As Beatrice showed you, we have nothing in this community, so we're really working towards creating more hospice residences in that community. We also learned that there was a lot of education and support that's required for hospitals, for our community partners, really around understanding a palliative approach to care. And so we're looking at how can we build capacity in our providers around palliative care. A couple of things that in terms of success factors and why this program has been successful, and Beatrice and Kathleen and I were reflecting, we're really, really proud. It's a small program, but it is a catalyst for future change because it's illuminating the need, and it's created partnerships that are creating services that didn't exist independently. But the key enablers has been the shared leadership between the hospital, the community. It is about the co-design and the co-development, implementation, and management of this program that makes this work. And that's the heart of integrated care, is partners coming together to create more together than they can individually. And as I always say, we need to better healthcare overall, but we have to get it right for people at the end of life. It's the right thing to do, and we're really excited that we've been able to do some of that in our program. So thank you very much. Thank you.
Thank you very much, ladies. What a great start for this session. Now, it is difficult because this is a big auditorium, but if any of you have any questions, if you can make your way to the mic in the middle of the room, that's great. Looks like first question. Yeah.
I ran up here. That was an excellent presentation. I really appreciate both the demonstration of how the program works, the outcomes that you're getting in a very clear and concise way. So thank you for that. I wanted to know what approaches that you've used with the hospital staff to facilitate those early. It was amazing to see the Q1 to Q4 change in the referral pattern. So I wanted to know what you guys had done to be able to support that.
A lot of lunch and learns, a lot of inviting myself to meetings with social work, a lot of going to physicians, general internal physicians that I have relationships with in the organization, and leveraging that to have that little discussion, and really bringing up the fact of, when we look at the fact that they triggered this, they are possibly approaching that end of life, that last year. Let's talk about X, Y, Z. And then you started to see a little light bulb. And then why don't we bring in social work and have this conversation? That plus having the Dorothy Lake coordinator coming in at least once a week, meeting with social workers on the units, having those discussions as well where they can identify and say, you know what, why don't we go talk to the physician about this? Me, for the most part, was just inviting myself to things to talk about it.
That's great. I heard yesterday a phrase about a really pushy navigator, a pushy connector, and I think what you're describing there is just get yourself in and around your partners, and I really like that, going into acute care and pulling out. Yeah. Joachim?
Thanks very much for the presentation, very interesting and important.
I wondered, since I understand you recruited patients through hospitals or within hospitals, what about the pros and cons for recruiting in hospitals as compared to through GPs or district nurses or community nurses, home care nurses?
Yeah, that's a great question. I think it's where you start. So our area, our community, our hospital doesn't have a palliative care philosophy, but we have a lot of negative palliative care outcomes. So that's how we got the funding. We went to our foundation, to donors, and said, hey, lots of people dying in the hospital, we can help them. And community would be our next if we are allowed to scale and spread, but it was our very minimal funding that we received, and stretching it out, thanks to Dorothy Lee, thanks to the donors, the place to start was the hospital. But the next division is upstream, starting with our primary care providers, starting with our community partners, and getting people engaged earlier when they have a year or more in their journey. But we have to start somewhere, and I think the burning platform was, how do we help the hospital, and then how do we show outcomes quickly, and then how do we get more funding from our funders and persuade them to change policy, and that's where advocacy comes in, to actually make it available to everyone. But when you start in an area where there's no palliative care philosophy, learning or understanding, you start with the most expensive part of the system, the high risk. When you show benefits there, you have funding and momentum to spread it elsewhere.
That's a very honest and pragmatic answer. Yeah, so follow the funding. Thank you very much, ladies, for a great start to the session. Thank you again. And we're now going south to Latin America, and it's my great pleasure to introduce Wilmer Sancho and Wendy Lopez Vargas, who are going to talk about the great work that they've been doing to pull together a collaboration across Latin American countries who are united in their passion to improve palliative and end-of-life care. So, Wilmer, thank you.
Hello, everyone. Good morning. Thank you very much for this opportunity, and thank you very much for attending this session. It is an honor for me to be here and to share about this initiative called Open Table Philosophy, Establishment of the Integrate and End-of-Life Care Working Group in the Latin American region. This work has been developed by the Technical Secretariat of ICIC Latam, led by Dr. Rocio Sáenz, with the participation of Dr. Ingrid Gomez, Dr. Claudia Collado, Master Paula Pinto, Dr. Cristobal Bacareza, Master Luis Solís, Bachelor Wendy Lopez, Josel Quesada, Leonela Castro, and myself. Today, I have the chance to talk about this experience. Okay. In terms of background, I would like to share that in 2022, an important step was taken with the creation of the Latin American hub of the International Foundation for Integrated Care, ICIC Latam. And this hub has the complexity and also the strength of being formed by researchers from different countries in the region. As you can see in the map, we have participants from Mexico, and with participation the Dr. Julieta Lopez, University Veracruzana, Nieves Ehrenberg, and Dr. Galileo Perez, individual participation, Dr. Victor Rios Cortázar from Autonomous Metropolitan University. In Costa Rica, we have the participation of Dr. Rocio Sáenz, Dr. Ingrid Gomez, Master Luis Solís, Bachelor Wendy Lopez, Josel Quesada, Leonela Castro, and myself from the University of Costa Rica. In Colombia, we have the participation of Dr. Eduardo Guerrero, Dr. William Robles, Dr. John Cruz from the Colombian Association of Public Health. In Bolivia, we have the participation of Dr. Christine Lanes from Participation Individual. In Chile, we have the participation of Dr. Osvaldo Artaza from the University of the Americas, Claudia Collado, Dr. Claudia Collado, and Dr. Cristobal Bacareza from University of Chile. And finally, we have the participation of Dr. Gaston Perman from Italian Hospital of Buenos Aires. Because of this, we had the challenge of finding a way to organize ourselves to work together, and we want to support the promotion of integrated care focused on people, families, and communities in the Latin American region. In this context, we created a philosophy of open table where professionals, work teams, or regional groups are invited to join and create new working groups. And these groups focus on topics that help promote integrated person-centered care in the Latin American region. Okay. And to make this open table philosophy possible, we worked together with the members of IFIC LATAM to create an organizational structure. And this structure includes a system that allows professionals, work teams, or regional groups to create new working groups on topics related to integrated care that are important for the Latin American region. The process of building this structure took more than 2 years of continuous work, and it brought together a diverse groups of organizations and people who share a commitment to improving integrated care in different contexts across Latin American region. We held many working sessions to review and reflect on what would be the best way to reach our goal. And in the end, we decided to create an organizational structure based on the idea of working groups. Throughout IFIC LATAM, we support professionals, work teams, or regional groups who want to create and share knowledge about integrated care in the region, whether they are already working on it or just starting. And we have the IFIC LATAM offered support to these interest people. This support includes identifying key areas of interest, building a work plan, and helping with the implementation of that plan. We also help promote the work so it can reach more people in the region who are interested in the same topic. And the image on the screen shows the organizational structure of IFIC LATAM. It includes the general coordination with the participation of Dr. Rocio Sáenz, General Coordinator of IFIC LATAM, Dr. Ingrid Gomez, General Coordinator of Technical Secretariat, and of course, Fiona Lane, IFIC Communication Director. The Technical Secretariat, the Advisory Council, made up of people from different parts of the region, and the working groups. All these parts work together under the open table model and the values of IFIC LATAM. Okay. As for the results of this Latin American effort, I would like to highlight that we have created a strategy to form working groups in the region, and we have already established the first official working group of IFIC LATAM. The first group is focused on integrated care and end of life. Forming this group took more than a year of joint work with people interested in this topic. The first people involved were Dr. Claudia Collado and Master Paula Pinto, both from Chile. We had regular meetings to share ideas and create joint initiatives, and which are now part of a work plan and clear roadmap. One of the key factors in forming these groups was the strong interest of its members in generating and sharing knowledge with other actors across the Latin American region on integrated care and end of life. And today, the group includes people from different countries, for example, Costa Rica, Colombia, Chile, Dominican Republic, and Argentina, who are highly motivated to join efforts and share practices and knowledge that can help in their local context. Our goal, IFIC LATAM, is to continue creating more working groups in the region to support the promotion of integrated person-centered care for individuals, families, and communities. And we are also working on forming new groups on topics such as local experience of integrated care in Peru, competence for integrated care training, and integrated care for older adults. We hope to continue implementing this strategy and supporting the growth of working groups across the region. To finish, I would like to share that this initiative has helped us create a strategy to join Latin American efforts, and these efforts support the promotion of integrated care focused on people, families, and communities, considering the complexity of the Latin American region. Also, we believe this is a strategy that can be used by other groups to encourage the participation of professionals, work teams, or regional networks in the topic of integrated care. Finally, I want to highlight the image on the screen. It shows a session of the working group on integrated care and end of life with people from different Latin American countries taking part. And of course, we invite more professionals in the room to the Latin American to join future working groups or share their own experience. Thank you very much for your attention, and also want to thank Fiona Lane, Nef Delide, and all the IFIC team who have supported this initiative. In a few moments, my colleague Wendy Lopez will now share more about the working group we have established. And again, thank you very much.
Thank you so much, Wilmer. And we're going to move straight on to Wendy Lopez Vargas, who's going to tell you more about the living, breathing community that is now being established as a network, having built on the structure that you so elegantly described. So thank you very much, Wendy.
Well, first of all, good morning. It's a pleasure to be here, and I want to thank to the organizers of this event. It's a huge event and a beautiful event. As my co-worker Wilmer said, I'm going to talk about towards building a Latin American community on integrated and end-of-life care that is related with the presentation that Wilmer did before about the open table philosophy. As a part of the background, as Wilmer said, we work on an open table philosophy that allow professionals, work teams, and regional groups with to the formation of new work teams who are interested in integrated, person-centered care for individuals, families, and communities in Latin America. As a result, we create an integrated and end-of-life care working group who has the interest of advocacy, training, and education initiatives on integrated and end-of-life care in collaboration with the civil society, healthcare professionals, academia, and policymakers. As a part of our approach is we need to say that the formation of this group of professionals interested in generating and sharing knowledge of end-of-life care needs development of work session. In total, we developed 13 sessions of constructive dialogue with the Technical Secretariat of IFIC Latam. And in these 13 sessions, we try to define a common objective. And this common objective was the creation of a roadmap for the future actions. And at the end of these 13 sessions, we will able to create the initiative End of Life and Integrated Care Workshop Series Practice and Challenges. That these End of Life and Integrated Care Workshop Series Practice and Challenges had two workshops. The first of these workshops was named Deconstructing Knowledge on Integrated and End-of-Life Care from Latin America Perspective. And in total, we had 150 participants registered from the region. In this first workshop, we tried to explore the knowledge of and practice through the participant experience. It's important to say that, as Wilmer mentioned before, The open table allowed and invite people from the region to share their experience, their knowledge about different topics related with integrated care. And the first workshop had this intention to know the practice and the experience of the participants. As a result, we identify of priority topics in governance, participation, and cultural relevance to establish a Latin America community on integrated and end-of-life care. About the second workshop was called Towards the Creation of a Latin America Community on Integrated and End-of-Life Care. In this case, we had 192 registered participants in that session. And the idea was make the presentation and validation of the themes related to the governance, participation, and cultural relevance. That it was strictly related with the first workshop. And as a result, we tried to join the definition of priority topics to guide the formation of this new community to practice. As an implication, as I said before, we identified three main areas. The first one was the governance, thinking a network that coordinates interests and resources toward common goals. The second one was the participation, understood a society that influences, decides, and engaged in end-of-life actions. And the final one was the cultural relevance, end-of-life action center on individuals throughout their life courses. With all these scenarios, with the governance, the participation, and the cultural relevance, we are trying, the next step for us will be define an action plan to develop initiative within these key actors that we are working on. This is basically our new group that is related with the open table philosophy, and we're still working on this process. And this is what we want to present today in this event. Thank you so much for your attention.
So Wendy will be joined by Wilmer, and these two papers are now open for any questions. Again, just use the mics in the middle of the room, or anyone who's online, feel free to ask a question live. Could I maybe kick it off by asking you, have you connected with the global echo on palliative and end-of-life care that the University of New Mexico offers?
Okay. Well, can you repeat again slowly?
The Global Echo on Palliative Care is an online tool.
Mm-hmm.
Yeah.
Mm-hmm. Yeah, it is online. We had some meetings with people from Europe, specialists in the end-of-life care, and we trying to share the knowledge. We try to learn from them, and also we trying to communicate all our experience online and different in our website and different spaces.
I'm fascinated by the breadth, the scope of your collaboration across so many countries, and I'm curious about what cultural differences have you identified. Would you like to talk a little bit about that? The cultural differences between the different Latin American countries in their attitude to death and dying?
Mm-hmm. Well, I think it's important here to talk a little more about every workshop that we had. In the first one, we had people from the health services, policymakers, and even people from the society. So I remember we had people from Argentina, and this guy was part of the army of Argentina, and he started to talk about the end of life in a different context that, for example, in Costa Rica, we didn't have, that is to lose people for army actions. And that is impressive because the idea of the end of life changed a lot. It depends on every context. So the most important part here is that with this little difference, some people think about the end of life like something sad, something terrible for their families, and other people think that it is part of the life, and as part of the life, we need to learn how to go through it. And for that, it's important to build this community around this initiative to learn more about it and to be strength and go through this event that is part of the life.
I guess that understanding context and culture is a lesson that applies across the spectrum of integrated care, not just at palliative and end-of-life care. But I was given a very practical example by your colleague Claudia Collado from University of Chile, who was talking about the first death week that she ran in Chile. Are you linked with that work? Would you want to say something about it?
Yeah, that is one of the initiatives that we share in these workshops, and we hope to share this in the future. Because, for example, Claudia talked about the Dead Week in the University of Chile, but people from Mexico talk about the experience of palliative care of people and how the community is important. So it's share information in this workshop about different stage of end of life.
And I was very struck by one of the messages that Claudia shared was that some of the imagery used in Chile had to be different from the imagery that was used in Mexico because it just doesn't translate across the different civil societies. So I wonder if you've been able to connect the different civil societies, the different citizens around this agenda. Do they come together across the countries?
Yes, as I said, the first, let me see. The first workshop was, had the objective to find these people interested around the end of life. So there was people from health services, from civil society, and from policy, the policy area. And these people from the civil society, they share their experience as with family, with friends about the end of life. And that was the example of this man from the army in Argentina. This was an old man sharing that experience with us in the workshop.
Okay, thank you. Well, we look forward to learning from your experience. I know in Scotland we have compassionate communities as something we're very interested in, and I know colleagues from Sweden are nodding, they similarly are. But we have compassionate communities in Colombia. So I think that there's a lot that we can learn from Latin America as we move forward. So thank you for sharing your excellent initiatives. Thank you. So I'm now going to move us on to our next two presentations. The first one is going to be from Professor Joachim Olin, who I had the pleasure of meeting last year or the year before in Sweden. He's based at the University of Gothenburg and was the former director of the Center for Person-Centered Care at the university. but you're also a consultant nurse in palliative care, so you're going to talk on a very practical topic today, something that really challenges, I think, many systems, how to integrate palliative care with acute surgical care. Thank you.
Thank you so much for the introduction and the opportunity to present here. And I'm replacing my co-author, Susanna Berling, who couldn't come. And we've done this study together, but you find her name in the program. Where do I change the slides? Is it? The big green thing? Yeah, it works. Thank you. So palliative care is an approach focusing on amelioration of suffering and improving quality of life. It can be given in parallel with disease-targeted treatment. And thus, early integration of palliative care is argued based on growing evidence on its benefits for patients' well-being and also their family members. Its strength is a focus on the person, whereas oncology, for example, is said to focus on the disease. And palliative care consultation services with specialists from palliative care services might function to support palliative care integration outside specialized palliative services. And through our collaboration with the Palliative Care Consultation Service, we research a practice-driven quality improvement project for patients with pancreatic cancer, and they were cared for in a surgical clinic or department. So the aim was to examine a practice-driven change intended to integrate palliative care early with surgical cancer care for patients with pancreatic cancer. As you see, we put 2 research questions for the project. And the quality improvement project we studied was practice-led quality improvement, a joint collaboration between Palliative Care Consultation Service and a surgical clinic. And the previous routine, you see on the left, used to be an initial outpatient visit for the patient with a surgeon and a nurse, and they informed the patient and the family members about the diagnosis and level of treatment. And there were no routine follow-ups, but the patient was encouraged to contact the nurse if needed or when needed. And in the new routine, you see to the right, the usual care was complemented with the nurse offering patients a palliative consultation with a physician, nurse, and social worker, all from the specialist palliative care service within the hospital. They supported with assessment of symptoms, appropriate level of care, information regarding possible supportive health care, and societal and community resources. And if required, an additional consultation could be scheduled. The overall design was interpretive description, which is grounded in practice, knowledge, interests. And the inner context for the study was the university hospital then, which is one of the biggest cities in Sweden. And at the time for the project, the specialized palliative inpatient ward was closed. And the hospital was in a transitioning phase for the specialized palliative home care service. The outer context was hospitals being the most common place to die in Sweden. And our country has a beverage tax-based, publicly funded and highly decentralized healthcare system. And there was an ongoing, or is still, a reform, a national healthcare reform towards person-centered and integrated care. So within the governmental governance, there is a clear independence for how to locally provide healthcare in the regions and municipalities. And as a result, palliative care consultations and the practice are practice-driven, and there doesn't exist any
a particular policy for it. And we applied qualitative data generation methods to different participant categories and a purposive sampling. And in total, there were 17 professionals and 2 patient representatives participating, and the data was analyzed iteratively through constant comparative analysis. The quality improvement took place in an intersect between 3 main actors, in red here. The patient and the family, the palliative consultation team, and the patient responsible surgical team. And patients were not involved in developing the practice design, but their conditions, situations, and experiences significantly affected the practice. And the collaboration constituted a process that illuminated similarities and differences in perspectives, practices, and needs. And that took place in relation to the local care culture, the local and regional healthcare organization, and the societal context and events at the corner of the figure here. And within these areas, prerequisites for integration were primarily the health professionals' motivation, the ways patients were offered the opportunity of a palliative consultation, the collaboration between health professionals involved, and the practice process of the palliative care consultations. And the intersect between the 3 major actors involved first, palliative care being a particular sensitive topic talking about, which became a key challenge for the surgical team in broaching the subject with patients. And then diverging perspectives on patient needs and palliative care practice, which were about collaborating teams, highlighting different perspectives on the patient needs and personal responsibilities, professionals' personal responsibilities. So, for example, the palliative team and the patient representatives advocated for proactive actions that conflicted with the surgical team's view. And third, divergent perspectives on palliative care integration and knowledge gap were disclosed in discussions in follow-up meetings with the 2 teams about broadening the specific patient group and to include patients eligible for surgery and those referred for oncological treatments and all pancreatic cancer then. And the surgical team appeared to show some degree of reluctance due to an assumption that these patients were still holding on to hope and not ready for palliative care. While the palliative consultation team talked about the surgical team to not sufficiently identifying palliative care needs and subsequently recognizing what this consultation team could assist with and support. And there were also differences in organization of palliative care practice and the consultant role related to a mismatch of expectations and needs. The palliative consultation team described themselves as unique in their way of operating different from other hospital consultants, and which usually only are physicians and not a team, in addition to that. And the change consultation, finally, were perceived to meet patients' needs and something positive for everyone involved. But unmet patient needs were disclosed by both the surgical team and the consultation team. And the timing in relation to sudden deterioration was an issue. And one of the social workers in the consultation team, for example, said that once we could inform the patient of what's to come, and it isn't acute, it often went quite well. But when it was like, oh, we're here, and you need help right now, and when the pain is impossible, and it's a crisis and panic right now, and the patient can't stay at home any longer, that's when it's incredibly difficult to only say, yes, but we're here now just to give you little advice. So the result confirms the known clash between a curative and palliative treatment culture. as differences and challenges in focusing both the person and the disease, and that the success of integration requires joint efforts and collaboration between healthcare professionals. The perception of what should be integrated is related to an understanding of knowledge gaps within the organization and also understanding of what the palliative care is as a concept. The when to integrate differed, as the ambition of earlier from the palliative team did not correspond to the surgical team's expectations. And then how to integrate also involves who is responsible for the integration and where it is best integrated, which is hampered by the lack of consensus within the palliative community about how and when to integrate. And the bottom-up driven practice change needs to be understood in relation to the premature national policy and a perceived mission for the palliative care consultant team to have an educating role, to educate the other health professionals within the hospital and elsewhere. So, in conclusion, we found barriers for the integration of palliative care related to differing perspectives on palliative care, integration and roles, and an internal organization of palliative care practice and patient needs. An early integrated palliative care organization is dependent on both specialized and non-specialized services, and the interprofessional collaboration and the structures from both sides, let's say. And within a practice-driven palliative care initiative for integration, expectations of what, when, and how to integrate needs to be unpacked and considered thoroughly. And behind the barriers disclosed, there is a need for a supportive policy for a palliative consultation services that include how to contextually adapt and tailor it. So many thanks for your interest. Oh yeah, okay.
So, thank you very much for that, Joachim. Really thought-provoking, and many years ago, very many more years than I care to remember, I was a physician as part of a palliative care team in an acute hospital in London. And, you know, I was reflecting, listening, that sometimes the consultations were palliative care only, but others, it was palliative care and surgical team together. And I guess I didn't think enough about the difference between those two different modes of interaction. Do you have any thoughts around when might be the time to have asynchronous consultations, you know, consultations separately with patient and palliative care team?
Right.
You know, is it always better to have it together, or do you think sometimes they are better separated?
Well, hard to say. I think if the consultations are together with patients or family members, there's always a risk for power if there are too many professionals at the same time. So I think and this palliative consultation team usually came, there was a practice to be a physician, a nurse, and a social worker. And, you know, if the patient were alone, then it's 3 against 1. So there's still a power in that situation.
Do you have a sense of, sometimes we talk about the best placed person, from the team, maybe the lead on the engagement?
Yeah, well, what I didn't say, what we have in the data is that the palliative care consultation team was with 3 professionals then, were kind of informally led by the physician. But at the surgical clinic, outpatient clinic, there was kind of, the consultants met primarily the nurse, who was a special clinical nurse with special responsibility, and met patients with individual consultations, in addition to patients' consultations with surgeons. So there was kind of a clash because the physicians kind of talked to the surgical team as he or she approached another physician. But the nurse had, another kind of mandate. So there was a little bit of a clash in that regard. Does that relate to?
And I guess patient choice has to come into this. You might have to adapt the offer according to the patient's sort of, personality and maybe communication style.
Oh, yeah. So, yeah, exactly. And so my example with that kind of different approaches from the different teams was kind of, they complicated because the palliative consultation team had suggestions to change prescriptions, for painkillers and so forth, and social support for family members to have relief from their work and so on. And there was a lot of paperwork that needs to be signed by the surgeon. So they kind of added on the workload for them instead of, and you could, and maybe it was because, the patients with pancreatic cancer are very fragile, could rapidly deteriorate and have increased the needs. So maybe it would have been better for this particular patient group to be referred to specialized palliative care much more earlier on.
Yeah, absolutely. I was struck by something else in your presentation. You talked about hope was something that was used as a, we don't want them to lose hope by being referred to palliative care. Can you talk a bit more about that? And how do we challenge that perception?
Yeah, I mean, there were clearly they perceived hope in different ways. So the surgical team were really kind of tuned into hope as a treatment for cure. And while the palliative team members were considering hope to be much more wider and considering that palliative care is a proactive, thing that we want to do a lot of things to supporting people. And the kind of old or the existing idea about that end-of-life care is about when you can't do anything. And that's the kind of the clash between these two perceived views.
Absolutely. So there's lots more to do around the public awareness and education.
Yeah. And that hope is, of course, both about an object, what you're hoping for, but it's also a process to experiencing and being in hope and feeling.
Absolutely. And living the best life that you can.
Yeah,
for the time.
And to kind of reformulate and find out what that could be in the new situation.
So I look forward to hearing more about the next stage of your research.
Thank you so much.
Thank you very much, Joachim. And our final presentation for this session comes from Professor Cecilia Larsdotter, who, again, working in the same Sweden public health system, but this time you're based in the university within Stockholm, and you've got a particular research interest in a public health approach to palliative and end-of-life care, and also using improvement science. So I'm looking forward to hearing about your work. Thank you.
Well, thank you so much for that introduction, and thank you for inviting me. I'm going to give you some results from a large research project concerned with the place of death that Joachim and I has been working on for several years, together with other colleagues from a bunch of other universities. And so we're concerned with a place for care at the end of life and place of death, and the factors that determine who dies where and why, really. So the significance of place then, why is place important? Well, place, to start with, as we define it in the Swedish system, is home, it's hospital, it's nursing home, and other places like public places. And place of death is an indicator of the structure and organization of palliative care in a country. It's a rough measure, but it indicates the way that palliative care has been organized. It's also associated with end-of-life care quality. We know that there are some evidence supporting, saying that care at home is associated with well-being, whereas dying in hospital, for example, is associated with futile treatments and not so good symptom treatments. Dying in the preferred place is also a quality indicator in Sweden and in many other countries as well. And as Joachim said, in 2012, hospital was still the most common place to die in Sweden. So palliative care then should be integrated early and should be integrated in all places where people die, regardless of diagnosis or care place. But about the Swedish context, we're a small country. I don't know if I can point with this one. Can I? Yeah, that's Sweden. And if you look at this map, it's the global mapping of palliative care that has been done. And according to this map, we have an advanced level of integration of palliative care units in the country. In reality, we know that there's a great variability in palliative care beds and home care teams across the country. We have 22,000 annual cancer deaths. It's the second most common underlying cause of death in Sweden. The first one is cardiovascular diseases. And we have 74,000 new cancer cases each year. And all those 22,000 deaths are eligible for palliative care because they have palliative care needs or potential palliative care needs. And as Joachim also mentioned, we had in our Swedish general health policy, we do not have any statements about palliative care really, but in 2013, as a response to that, there was a launch of two policy documents for palliative care. And as Joachim also mentioned, we have an ongoing, since many years really, transition towards integrated person-centered care in Sweden, which is aimed to bring care closer to people's home. And this decentralized healthcare system that Joachim talked about, I just want to put palliative care into this context a bit. The National Board of Health and Welfare in Sweden are responsible for policies, and that's the national policy for palliative care, for example. We also, I think, are among the best in the world to produce national guidelines for different diagnoses, and in this case, for all cancer types. We have a national cancer strategy, and we have a national quality register for palliative care. The governance and organization and provision of palliative care is really decentralized between those 6 healthcare regions, from the north to the south in the country, and we have 290 municipalities, and the municipalities are responsible for nursing homes and for the general palliative care. And we also have regional cancer centers in the country, in each region, who consists of cancer leads, that's clinical experts, and patient representatives. And adding to that, we have in a few regions palliative knowledge centers who are supposed to educate professionals, to provide knowledge translation into practice. So we wanted to see if there was a positive policy response after the launch of this national policy for palliative care. And we assumed that if there was, the amount of hospital deaths would decrease and the number of home deaths would increase in the country. I think I lost the slide. See if I can go back. No, it's gone. Okay. So what we did was that we first wanted to look at if there was any trend in the place of death between 2013 and 2019. And the reason for stopping at 2019 was that then there was a pandemic, and that would have sort of been a confounding years to compare. And we did find a trend. There was a significant downward trend in hospital deaths in the population living at home and dying in hospital. So there was a positive trend in that aspect. There was no significant trend for those who resided in nursing homes in the amount of hospital deaths. However, this trend it was really inconsistent. It had great variations between the years and between the healthcare regions. These are the actual numbers in change between the different places. And in the overall cancer population, those who died in hospital, there was a great variability between how many had access to specialized palliative care, but in the overall cancer population, around 30% did so. But there was also a great variability between the healthcare regions. And so the factors that contributed to this downward hospital death trend was that among those who resided at home, being old was one important factor for the downward trend. On the other hand, there was an upward trend for dying in hospital among those who were old residing in nursing homes. So one interpretation is that we managed to keep the older people out of hospital and instead in nursing homes, but when they come to the nursing homes, they're not able to provide palliative care, so then they end up in hospital anyway. That's one interpretation. Another thing that contributed to the downward trend was that was the fact that of not using specialized palliative care at the end of life and being widowed or divorced, and not receiving the ICD-10 code for palliative care. However, for those who did receive this ICD code and having used specialized palliative care at the end of life, there was an uprising factor. And then we moved on, because then we know that still most people still die in hospital. We wanted to know what Swedish people do prefer. And then we asked a representative sample of the Swedish population, imagine that you had a serious illness and less than a year to live. Where would you prefer to receive care and die? And more than 50% prefer to be cared for and die at home. A little bit fewer wish to die at home than to be cared for at home. We also wanted to know who preferred what. And then we found that those who had a strong preference for home death and home care, they were slightly older. There were slightly more women who were more educated and who had a more comprehensive understanding of palliative care than those who who had a preference for hospitals, because in this group there were slightly more men, and they were slightly younger and slightly less well educated, and had also a rather low understanding of palliative care. The next step was to analyze the content of palliative care information in those national guidelines for different cancer diagnoses. And what we found was that they varied a lot, from only mentioning palliative care without any explanation to detailed discussions about palliative care practices. We also found varying conceptualizations of palliative care, from to be only care for the dying to being integrated care with disease-specific treatments. And finally, we took all those results, and then we interviewed those cancer care leads and patient representatives in the regional cancer centers. And then we presented those results for them, and we asked them how they perceive the state of governance and organization of palliative cancer care today. And they said that basically that the problems, the challenges with palliative cancer care today is related to the fact that we have a very non-directive palliative care policy. It's recommending and it's informing, but it's not directing. And there is also this multi-level knowledge gap about palliative care from political and governance level down to the public and professional level, which in turn then causes fragmented healthcare systems based on uninformed decision-making on governance level and on professional level. And this in turn then brings a sense of a lack of ownership. And this is also very much related to the fragmented healthcare system, because no one really feels responsible for the governance and provision of palliative care in those 290-something municipalities and 6 healthcare regions. And this, as they perceive this, are the main reasons for the inequalities that we see in the service provision in the country today. So to conclude this, I think this is kind of an illustration of all the challenges there is with integrating palliative care in a country. We still have a lot of work to do to distribute and provide palliative care across the regions in a way that sort of hinders this inequality. Yes, thank you.
Thank you very much, Cecilia, for a really interesting study. And I was sitting there as a geriatrician thinking, what if this was frailty and not cancer? Mm-hmm. Would you think you would get the same sort of pattern of results?
I do, actually. We've done these place of death studies, mm-hmm. And we've looked into many different diagnoses. And we've also looked at the overall population, and the results are more or less the same. So yes, I do think so. Okay. And you would have thought that because cancer was one of the first diagnoses that was of interest for palliative care, you would have thought that these results would have been better, so to speak, when it comes to the cancer population, but it isn't, unfortunately. So.
No, so a long way to go yet. Any questions? Again, microphones are available in the middle of the room. Feel free to stand up and move. Yes. I'll just repeat the question for those online. Was there any correlation between availability of services and the places of death?
So one of the challenges that we have in Sweden is that we don't really have a good, we don't have an overview of the exact number of palliative care beds or palliative care units, but the information we have is that we know of the establishments of palliative care, and those numbers are dated back like 6 years or something. So we haven't really investigated that, but we have reason to believe that this is, of course, one of the situations. But on the other hand, the capital region, Stockholm, which is where I'm based, we have what many people will say, I think, almost an over-establishment of palliative home care teams, and still just as many people die in hospital there. So, yeah.
The issue around equity is, I think, a really live conversation in so many countries. I know data from Scotland, from our National Palliative Care strategy consultation, shows that socioeconomic data is really determining places of death. So you're much more likely to die at home or in hospital in lower socioeconomic communities, and then the more affluent are more likely to be able to either die at home or in hospice. So I think we've, the themes of equity that have resonated throughout the conference, I think, have a real relevance for the palliative and end-of-life care agenda. Again, another hot topic for palliative care communities in the UK is the issue of assisted dying legislation. And I know there is legislation in Canada already, so I just wonder, where are you in Sweden with any consideration of assisted dying?
I'm probably not the right person to answer that. I think that Joachim or maybe Stina would be better to do that. But we have a sort of, it goes in kind of cycles, the debate, and there has been a debate quite recently about that. But I think, correct me if I'm wrong, but I think that we still stand within the two very strong opinions for or against. I don't think there's any change. So it's not something that we expect to come in the news years.
So I'm seeing a nod from your colleague there. I guess in the UK, both in Scotland and in England, there's debate going through Parliament at the moment. So something certainly that has mobilised the policy advocacy for more access to palliative care, certainly. One last question, if nobody else has got questions, if I could maybe just ask about the preferred place of care, preferred place of dying. It's really good quality information at a micro level, but it's really hard to capture that kind of data at a population level. What's been your experience of trying to use preferred place of care as an outcome measure for bigger populations?
So this study that we performed was part of a public opinions, an annual public opinions survey, which is being done in Sweden. And so as a researcher, you have the opportunity to pose your questions. So that's what we did. And we actually also asked the question if they had a previous experience of palliative care from a relative or so, but we had no associations there. And in terms of the research, the evidence which is out there about the preferences for place of death, there's been no really difference between those who are ill or those who are supposed to be healthy. So I don't know. I think it's difficult, and it's also difficult to say that I'm not sure that the goal is to sort of fulfill these 50 or 60% of dying at home, because there will always be people who cannot die at home for some reason,
And I guess I'm sure many of you who are working in this field will appreciate that it's an evolving conversation, and sometimes people's choices will evolve over the trajectory of the illness. So it's not something that we capture once and then that's it. You know, it got to keep returning to that choice, and see if we can support people's wishes.
I really think that when people answer that kind of question, it's based on the idea that you will get quality of care and you will have support for yourself and your family members.
Yeah.
So
Yeah. But the issue, big issue around, certainly in my area, up to 1/3 of households are now single-person households. So that influences, doesn't it, the reality of being able to have that level of support at the end of life. If you're living alone, you're very much dependent on that wider network, which takes us back to the compassionate communities that we talked about at the start of the session, and that lovely example from Toronto around, mobilising the spectrum of care and support from healthcare services, building on what's already there, layering on your specialist palliative care expertise, and being able to draw on the assets of the social networks and the community supports that are there for some of the small things that make a great difference. So thank you to all of our speakers for great contributions today. And if this is an area of interest, can I just highlight that on the conference app, you'll see a link to ICIC special interest groups. There's a special interest group on palliative care. There's one on compassionate communities. Please register your interest so that you can be connected with any newsletters or information around some online forums or activities for those that are interested in these topic areas. So thank you all, and go and enjoy your lunch and keep the conversations going.
put it, it is in the right order.
Yes.
They don't see our
slides.
Okay, just a second.
We need to know where we first start the session now?
Yes?
Okay.
Yeah.
Okay, they are going to do
Okay. Okay, then I open it and then I give you the space.
Okay, cool.
Can I stand here for a minute?
Yes.
Okay, ladies and gentlemen, it's time. It's time for strengthening leadership workforce capacity in integrated care. This is a very interesting session and quite a lot of people came. Wonderful you're here. Welcome. My name is Roelof Ettema. I'm your chair today. And I was lost, so it took a while to be here, just on the edge of time. I am a professor in integrated care in the Netherlands, leader research chair on personalized integrated care. And strengthening leadership and workforce capacity is a challenge, and that's where our presenters are going to talk about. May I ask the first one? And you introduce yourself, isn't it? Yes, okay.
Hello, my name is Niamh. I'm a research assistant in the National Rehabilitation Hospital in Dublin in Ireland. My presentation is called Challenges Are Also the Goal, Leadership Perspectives on Patient-Centered Goal Setting for Rehabilitation. So just a bit of background on this study before I go into it. So research has been done which suggests that a more interdisciplinary patient-centered approach to goal setting is beneficial to patients, specifically in a rehabilitation setting. So this approach has been shown to enhance personalised care among patients by aligning treatment with patients' needs. So in 2023, in the NRH, we began to introduce this process. So just a few more details about the actual new goal setting process itself. So in the hospital, we have an IDT team, an interdisciplinary team, a quality care team, and they work together alongside patients and staff to create the new goal setting process and the new goal setting document. So the way it works is when a patient is admitted, they first have a meeting with a nurse to determine their short-term and long-term goals. So the short-term goals will be underpinning their long-term goals. Following this, a goal-setting meeting with all the IDT staff is held, with the patient and then their family as well. So they all collaborate to establish how the patient's goals will be met. In terms of the actual documentation itself, the documentation asks which IDT members are present in that meeting, hopefully all of them, and it asks questions like how important is this goal setting to you and how close are you to achieving it. And there's 3 separate sections as well for the patients to fill in 3 separate goals. This would be on the new goal setting document. This is different from the more traditional approach where the goals were more determined by the therapist rather than the patients themselves. So this process spans from pre-admission to discharge as well as following them up post-NRH life. So before we focused on the leadership aspect of this study, when the new goal setting was introduced, we actually surveyed and interviewed staff and patients to gather their perspectives on the new goal setting process. So that was done at 2 time points. The first was straight after it was implemented, and then the second time point was a year later. So now this study has shifted the focus more towards leadership perspectives on the new goal setting process. So specifically, we want to know how their support or leadership strategies have facilitated or impeded the introduction of this new goal setting process. And our aim was to understand the barriers and the facilitators of this at a leadership level. So our method was quite straightforward. We conducted semi-structured interviews with managers across all disciplines and units within the hospital. This also included CNMs, so nursing managers as well, over the course of 4 months. So in terms of our interview schedule, there are questions like, how have you supported staff during the new goal setting process? And have you collaborated with other leaders during this time? And then we conducted thematic analysis to identify how governance structures and leadership strategies influenced both engagement and barriers to the implementation. So overall, 9 managers participated, and they had all been working for quite some time in the NRH already, so 17 years. And generally, they demonstrated a willingness to adopt the new goal setting process, but there were a few barriers in place, which I'll talk about now. So the first theme we found was a sense of isolation among the leaders. So this was the most prevalent theme seen throughout each interview we conducted. They felt like they were in some sort of middle ground between their staff and then the IDT quality care team, who were the ones really advocating for the process. So they were felt like they were being pulled towards 2 different directions. They felt they didn't have the sufficient knowledge of the new process to adequately address problems staff were coming to them with. So they felt like they had the same level of knowledge as the staff themselves. They weren't able to answer questions they may be asked. So one manager said, as a leader, I have no line management responsibility over any of the staff who actually work within the team. I lead by encouragement rather than authority. So as they said, they're not a line manager, so their role is more passive than they would have liked. Theme 2 is unrealistic patient expectations. So because the new goal setting process is more patient-centered, sometimes they might set a goal that they might not be able to meet. So this leads to disappointment among patients and among the staff as well. Again, this was one of the main things that was voiced to the managers. As well as this, the new goal setting document was more time consuming than the old one. So staff felt like they were spending a lot of time setting the goals, which is time that could be spent actually helping the patient. Again, this was voiced to managers who had no control over this and therefore could not advise their staff on how to proceed. So the third theme we found was old versus new. So there was kind of an attitude of, if it's not broken, don't fix it. So leaders noted how many staff seemed more comfortable sticking to their usual tried and tested ways of working and often compared the new goal setting process to the old one. One manager said that there seemed to be an attitude of everything old is always better, as you can see in the speech bubble. And there was also technical difficulties with the updated EPR documentation itself. The third theme was more positive, so it was optimism for its potential. So despite these barriers, leaders seemed optimistic concerning the new goal-setting process because they could see how much it benefits the patients and how they enjoyed how patient-centred it was compared to the old goal-setting process. So one leader said, now it is better because there is a protected focus on getting the patient's story and the patient's voice being the primary one. So implications and future directions. Managers recognise the benefits of the more patient-centred approach, but the sustainability of this new goal-setting process requires individuals to champion it from each discipline and leaders to continue to support their staff. Hopefully these insights will inform future iterations of the goal-setting document because it's still in the hospital, as well as similar quality improvement projects. More broadly, these findings could also be applied to other rehabilitation settings. So that's it. Thank you.
Thank you so much, Neve. Thank you so much, Neve. Wonderful. Are there any questions? No? Then I have a question for you. Did you consider interviewing patients?
We did. We interviewed patients and staff. So we handed out surveys and interviewed patients and staff before we moved on to leadership. So we did that at 2 time points.
And was there a kind of feedback loop from the point of view from the patients to the leaders, so they knew what the teams for the patients were?
Yeah, so the patients were giving feedback to the staff, and then the staff were giving the feedback to the leaders, the program managers. So it did kind of go in that order.
And what were reactions of the staff?
For the staff, the main thing we found was increased communication between disciplines, which was a very positive theme, as well as increased teamwork.
Okay.
Yeah.
And did you experience some difficulties involving patients? It's not their subject, isn't it?
Exactly. The patients seemed to enjoy how patient-centered it was.
Yeah.
So they were fully in control of setting their own goals. Yeah. So that could only be a positive for them.
And what made that there were some barriers for the staff? Because the patients enjoyed it, they saw it, and still there were barriers.
Yeah. There was a fine line between the patient setting their own goal and it being realistic or not.
Yeah.
So that's what I spoke about there, that it was a positive that the patient could set their own goal, but on the other hand, sometimes it wasn't able to be met.
Yeah.
Yeah.
Understand. Okay, thank you so much.
Thank you.
Yeah, there is a question. And the mic is over there. The mic is over there, very, very nearby. Please introduce yourself.
Thank you so much for the presentation. I'm Esma from Norway. You have mentioned unrealistic goals from patients, and I was wondering if there was something also about how to structure person-centered goals into measurable goals. Was there like some challenges around that from staff? How to transform the goals from the patient, who are quite broad, and into these measurable?
Yeah, so I think it involved a lot of communication between disciplines. So that would be the increased interdisciplinary aspect. So beforehand, each discipline would kind of set their own goal for the patient. But for this, they had to make sure that the patient's goal was at the center. Thank you.
Okay, Keith, thank you so much. Keith, thank you so much. Rebecca. And we agreed on you are going to introduce yourself.
Thank you. Hi, everyone, and thank you for sticking around to the end with us today. It's a pretty intimidating auditorium, but nice that there's just a sprinkling of people, so I don't feel quite as intimidated. My name is Rebecca Jessup. I'm an associate professor and an embedded clinician researcher at a health service in Melbourne, Australia. My actual title is I'm a director of a Centre for Virtual Health Research that we've recently set up, but I'm going to talk to you a bit today about a passion project of mine, and that is a peer navigation workforce, which in Australia is a relatively new thing. And we've been doing a lot of work in trying to develop a training package that can be rolled out nationally. And to do that, we actually wanted to develop this capability framework. And I'd just like to also acknowledge my team, Natalie, Susan, Don, Fan, and Simone, who aren't here, but I'm representing a team today. And I'd just like to start by acknowledging the traditional owners of the land on which all our research was done, the Wurundjeri people of the Kulin Nation, and to pay my respects to their elders, past, present and emerging, and to also acknowledge that sovereignty was never ceded in Australia. So our little hospital network, which isn't quite so little, forms the major provider of health services in Melbourne's north, and provides a hospital care to about 6,000 square kilometres, so right up into regional northern Victoria. It's a very multicultural population that we serve. About 40% of our population don't speak English as their first language, And we actually have over 100 languages represented with over 185 different countries of origin in our community. Our diverse community faces a variety of health and social challenges, including lower rates of health literacy, lower rates of education, and higher rates of unemployment than Victorian state averages. So I'm probably speaking to the converted here, and most of you are probably very much aware of the role of peer navigators. We first started having peer navigators working for us at Northern Health during COVID, and it was because we didn't have any reach into our diverse community in order to encourage them to get vaccinated. And frighteningly, our hospitals and our IC units were full of our diverse community members who had not got vaccinated. So we actually engaged with individuals who worked as peer health navigators during COVID to engage those populations in vaccination and monitoring when they did have COVID and early detection of deterioration. So the role of health navigators is particularly vital for these populations that are underserved and are hardly engaged with. I'm not going to say they're hard to engage with. Really, we hardly engage with them in the Australian healthcare system. So Australia's health landscape is really complicated, and I think it's probably very similar to the health landscapes of many of the countries that you're from. But we have many different pockets of care. We have different types of payment systems, a mix of public and private. We have state, federal, local governments all involved in delivery of social and healthcare. And it's really, really complex. And anyone who has ever tried to access care, who probably has a high level of health literacy, could tell you that it's actually incredibly complex, even when you know the system and you work in the system, to get the right care at the right time when you need it. So imagine how difficult it is for those people who find it difficulty accessing care ordinarily. The WHO a couple of years ago came out with a policy paper that identified that patient navigators or peer navigators, as well as health professional navigators, are an important asset to health systems worldwide, and that they're a promising solution to equity and access issues. However, existing programs globally vary in terms of context and setting, and therefore the practical implementation needs to be considered locally, and it needs to fit contextually to the local environment. So one of the biggest barriers we have in Australia to implementing these roles nationally is that there's really poor recognition of the skills that are required, and there's very little access to formal training. So that was something we worked to address, and we've actually developed a vocational education and training program that has just been released, that will be available for our TAFE sector, which is our non-university sector, skills-based training sector. And that will be available from the middle of this year nationally for people to go and train as health navigators. And as part of developing that training program, we needed to develop a capability framework. And we chose capability over competency because competency frameworks focus on tasks and measurable skills within the workplace. And having worked with health navigators for the last 5 years, in practice, the role is so much more than that. It very much is about skills and attributes that cannot necessarily be taught. And I think it's really important that we name those, because it's important that when employers are engaging individuals into these roles in their organisations, that they know the types of attributes and the personality traits that they want to look for, because these roles don't work unless these individuals have the right skills and attributes to engage people from their communities and get that relationship of trust established. So our co-design was a very, very comprehensive program of research that covered 5 sub-studies, and it's not within the capacity of this presentation for me to outline them all in great detail, but we did do a systematic review that was from 2007 to 2023, initially included 4,879 primary studies, and in our final that we did abstract and title screening for. In our final included studies, it was 95 studies, focusing on core competencies, operational skills and personal attributes of peer navigators. We then conducted interviews and focus groups with patients, with people who were working as navigators and with clinicians, and they were specifically at our health service. We used vignettes and a triangulation process to explore the capabilities and themes that were arising from those semi-structured interviews and focus groups. We then nationally interviewed employers of health navigators and subject matter experts working in universities across both health and social sectors. And that included experts in bicultural navigation, mental health, disability, cancer, chronic disease and aged care. And we applied a social ecological framework to identify workforce development themes. And then we ran a series of community co-design workshops, specifically with the populations that we found it hardest to reach during COVID, and they included individuals from our Pacific Islands, so Maori and Arabic-speaking, and our Arabic-speaking communities, which were individuals from a very diverse range of Middle Eastern countries, including Lebanon, Syria. So we have the largest Syrian refugee community in Victoria. Living in our area, Iraqi, who are largely a refugee group as well, and Egyptian. And this was the final capability framework that we developed, and it's a concentric model, so it's really important that it's viewed from the middle or the centre outwards. So it's the most important components of this role is getting someone who has the right innate qualities in order to do the role. And so I think attributes such as empathy, humility, resilience and desire to help others are essential components to that role. And then we want people who have actually got some lived experience or some tacit knowledge, which allows for livable, relatable experience that enables trust, fosters understanding and provides authentic insight into the barriers that people might be experiencing. Then there's the training, so this is the stuff that we can actually teach. So things like communication, particularly in motivational interviewing, cultural safety, health system navigation, and working within boundaries and managing self. And then that needs to be coupled with supervision and mentoring by health and social care professionals, so having the right kind of people to support you in your role, someone that you can go and talk to when you've got concerns about a patient that you're supporting, someone who can talk to you, make sure that you're working within those skill boundaries, that you're not providing health advice that you don't have the skills or qualifications to provide, and also that you've got that kind of safety net, because often these individuals are working within communities that they're from, and so there may be moments where they feel that they're very vulnerable and that certain situations have brought up personal traumas for them, and they need to have opportunities to go and speak to people about that. And finally, there needs to be access to reliable funding. This is one of the biggest challenges we have in Australia, is that funding tends to be piecemeal. Often it's research-based funding that runs out. So we need to have these roles recognised as a core part of the health system, not something that sits outside, and therefore we can activity-based, which is what the health system in Australia is based on. There's some block funding, but there's also activity-based funding, and these roles are not recognised. So we need to have reliable funding, we need to have regulation to ensure that there is consistent training of these individuals, that they have fair remuneration and representation, and protections both for the navigators and for the people that they're serving. And that's it from me. I'm happy to take some questions, and that's my contact detail.
Rebecca, thank you so much. Are there any questions? What I was curious about, it's a wonderful idea about these health navigators. That's wonderful. And you collected data on patients, patient carers, clinicians, employers. Were there differences in view?
That's a very interesting question. I think one of the challenges we found with clinicians was they didn't really understand the role and they were a little bit frightened about it. So that sometimes came across as some role boundary protection. You know, I don't want these roles to be established because I don't want them, they're going to take my job. But I think once we worked through what the roles actually involved, there was a lot of that discomfort disappeared, and once people could see the benefits in practice, there was a lot of engagement. So I think it's like anything new. People are a little bit distrusting to begin with, and then they come on board. I think the managers and the subject matter experts that have been working in this area for a while were all, you know, we need to have these roles and they need to be funded appropriately. The navigators themselves just felt like the roles were really worthwhile and it was an opportunity to give back. And actually, interestingly, patients, we had a mix of patients. We had patients who had worked with navigators and those who didn't, who had complex and chronic conditions. And the key theme was, I just want somebody who cares about me, who can listen to me and talk things through with me, who has the time, who doesn't make me feel like I'm rushed. And so they were the kind of things we were hearing from those different groups. It was different.
Yeah. Okay, thank you very much. Is there a question? Yeah, there's a question.
Hi there, just a really quick question. And you just kind of spoke to this a little bit around, you know, the challenges for funding and some people just, again, valuing just the opportunity to be in these peer roles. Is it always a paid position, or is there ever a bit of a continuum where they start as volunteers and move into paid? So the difference, if any of it, is volunteer.
Yeah, that's a really good question. So we have both in Australia. So I'm working with the largest cancer hospital in Victoria with a group of volunteer peer navigators, and I think with some health conditions there's a high level of motivation for and desire to give back, and so there is it is easier to engage individuals to provide those peer roles as volunteers, and I think they're getting other things back from that experience. So I think it's important to acknowledge that. I do believe that that we probably should be paying, because these are becoming roles that are increasingly necessary in our health system, and we need to recognise that. And so I'm a little bit uncomfortable with the volunteer aspect of it. But even when you've got volunteers, they still need to have the right scaffolding around them in order to do their job. So you still need to have funding to be able to run the programs adequately. So either way, you need to have proper funding.
Okay.
Thank you.
Thank you so much, Rebecca. Then Ellen. And Ellen, would you introduce yourself?
Hi, everyone. So I'm actually not Ellen. I'm Mary. We're co-presenting. Ellen's going to be second. Here she is. So my name is Mary Rowland. I'm a family doctor. I work in Kingston, Ontario, Canada. I work in a community healthcare setting. I'm currently the clinical lead of the Midtown Kingston Health Home, which was a new site that we have been building this year. And I'm really thrilled to be here today to talk to you about some of the work that we've done in Kingston on developing a regional strategy for educating primary care providers and building their capacity and skills in delivering trauma-informed care in our region. So just a very brief overview, although we could spend so much time on this. And the reason why I'm so thrilled to be here talking about it is because for me, when I discovered trauma-informed care, the literature around it, the principles and how they can be applied, it was absolutely a transformative experience for me. It changed my practice like nothing else ever has, and I don't know if anybody else has had this experience, but it really did change everything about how I practice, how I relate to patients, how I approach and understand them, and how we develop care plans together. And it's based on the literature from the original ACEs study, which was published in 1998 by Vince Felitti, and if you haven't ever read the original ACEs study, I would really encourage you to spend some time doing that on the plane on your way home. It is an incredible study, and the graphic here just sort of outlines very briefly that if you experience some adverse experiences in your childhood similar to those outlined up here, that it has incredible impact on your health later in life. And so, I mean, logically we can understand that if there were difficult things in your childhood like abuse, neglect, family chaos, you can sort of make the leap that, yeah, you might have some mental health problems later in life, maybe some substance use issues, but the ACE study showed so much more than that, that there's actually enormous increases in physical health conditions later in life, things like heart disease, cancer, COPD, even when you control for confounding factors like smoking. So it is one of the most important predictors of health in later life of anything we've ever discovered in medicine. And so it's incredibly important. So trauma-informed care is when you acknowledge the enormous impact that these adverse childhood experiences have on the health of your patients. And there are ways of applying it, and the principles of trauma-informed care are outlined here. And again, we don't have time to go into it because the talk today is mostly about the work we did in Kingston to provide education about this transformative approach to the healthcare providers in our region. And why do we care about this so much? We've talked about the quintuple aim, but I've even distilled it down to 3 here. And like I said, we know it's really good for patients. We know that if we use this approach when we are caring for patients who have high ACE scores or have experienced lots of adversity in their life, that it changes their health outcomes and it changes the way they're able to engage with care and engage with the treatments that we are offering. But the talk today, we're in the session about workforce capacity building. And so our experience in our organization, who more than a decade ago adopted an ACEs framework for all the work that we do, it permeates all of the programs that we take on and all of the ways that we deliver care. And we know that it's actually really good for providers. My colleague Rupa Patel, and I'm going to talk about her in a minute, and she's here, but we talk about it as burnout prevention for primary care. So there's lots of things in our setting and probably yours too that's contributing to provider burnout in primary care. There are so many things. But one of the things that we've heard over and over again from our colleagues is there are some patients that can present in really challenging ways, and it can be very morally distressing when you're trained in a medical approach, but what your patients are presenting with are social determinants of health, challenging behaviors, emotional dysregulation, addiction, substance use, family disruption, all of these things, and it's morally distressing when you're trying to apply a medical model and you feel like you're not getting anywhere or that you're not being very helpful to people. And so if we can train and equip our primary care providers in ways to approach patients and engage with them differently from a trauma-informed lens, using things like collaboration, choice, empowerment, developing safety and trustworthiness, which are the principles of trauma-informed care, it really changes how you feel about your practice and joy in your work, which we know again is a retention strategy. And it's good for teams. We've seen this in our organization. We're starting to see it in our region too, that whenever we do these trainings, whenever we deliver this kind of information to staff, you can see the team galvanize around this shared purpose, this shared mission. And again, it brings back the joy in work, and it's really good for team building and getting everybody on the same page. So that's what we wanted to do at a regional level in our region, is can we get everybody on board with this way of approaching patients and approaching delivering care. So again, our local context, Kingston is like a mid-sized city. We're about 175,000 people located partway between Toronto and Montreal in Canada. We have an OHT, which is an Ontario health team. It's a new way of organizing healthcare in Ontario, and we're part of the FLA, so Frontenac Lennox Addington Ontario health team. And I was around in sort of the early stages of this OHT, and we spent a lot of time thinking about what are the principles that we want in our health homes in primary care, and one of them was promoting equitable health and wellness, which sounds great, but what are some sort of actionable things that we could do to try to enhance this? And one of the things that the health home working group decided on was let's figure out how we can deliver trauma-informed care to everyone. So that's where our team came in. Again, that's just more about ACEs, but what we had identified was that there's a gap amongst primary care providers. In Canada, we talk about trauma-informed care fairly often, but what we were seeing with learners in our clinic and other colleagues in our area was that people didn't know how to translate the theoretical knowledge about trauma-informed care, but what does that actually look like when it's presenting in your office, and what are the actual tangible skills that you need to be able to engage well with patients. So we were very thrilled to have some partners working with us. So these are the logos. The Kingston Community Health Centers is my employer. TR stands for Teach Resilience, and we have a social program as part of our organization called Pathways to Education. People from Canada are probably familiar with that. It's a program to help high-risk youth complete high school, but the team in our KCHC who work in Pathways to Education were way ahead of the curve on trauma-informed care, and they had formed this social enterprise called Teach Resilience, and they had already developed a curriculum in trauma-informed care, and they were taking it out into the community and teaching it to community agencies. They had taught it to the teachers in our local local school boards, Kingston Police, Family and Children's Services in our area, they already had a great curriculum. It was primarily for lay people, and so then my colleague Rupa and I said, you know what we really need is a clinical module to go along with the Teach Resilience module, and so that's what we did in 2024. So the goal again was to enhance the trauma-informed education in primary care, and the way of doing this was to create and host an initial continuing professional development day for the primary care providers in our region. So we did this in the spring last year. I'm an assistant professor with Queen's University as well as part of my job. We were able to get this accredited for CME credits, so continuing medical education credits, and that was a way of drawing people to it, and it was funded by some very generous partners, including the Ontario Medical Association and our local OHT. We held it at our community health center, and again, it was co-taught. The morning session was done by the Teach Resilience team, so the Pathways to Education staff who have expertise in delivering it, and then the afternoon session was my colleague Rupa and I had put together the clinical module, so sort of some very practical applications for clinicians, as well as medical secretaries and other support staff working in primary care, so we taught the afternoon. And then the research part of it is that we had online evaluation forms before and after the sessions to see if we actually could show an improvement in the trauma-informed care knowledge of the people who attended. And these are just for people's interest, the learning objectives of this session were to get an understanding of what ACEs were and how they impact health outcomes, to identify common presentations of how trauma presents in a primary care setting, to be able to have 6 effective pillars to support those living with adverse childhood experiences, for providers to be able to evaluate possible triggers in their practice environment, so things that could be stressful or triggering to patients with a history of trauma within the practice environment. So we did some very practical exercises to think through the practice environments and changes that people might be able to consider making, to be able to apply the principles of trauma-informed care in their daily work. And then we did some case scenarios to really work through some practical approaches of ways that you can manage the emotional dysregulation that is a very common presentation of trauma in a primary care setting. So now I'm going to turn it over to Ellen, who helped us with our evaluation.
Hey, everybody. So my name's Ellen. I'm an assistant professor at Dalhousie University, which is in Nova Scotia, Canada. But at the time that this happened, I was working as an implementation lead for the OHT. So yeah, we did do an evaluation, as Mary was saying. So we had 48 people attend, and there were 6 different primary care practices that were represented there. We did look at if the session actually did anything that we wanted it to do. So we looked at people's trauma-informed care knowledge before the session, at the beginning of the day, and then again at the end of the day. So we found that 90% of people agreed that the program enhanced their knowledge, so either agreed or strongly agreed. And then we found a statistically significant increase in knowledge, which was about a 30% increase in knowledge, just to kind of quantify that. We also asked people what ideas the session had gave them for how they can incorporate it into their practice. And so people said that as a result of the training, they're now going to give patients and the people they care for more choice in their care. They're also going to think more holistically and empathetically as well. And that they now have a greater understanding for why people have the reactions that they do in a clinical care setting. We also got some feedback where people wanted more integration of consideration of Indigenous identities and people living in larger bodies in the training. And then we also had some clinicians from rural areas who were really interested in the training, but they said it was too far away from them because we hosted in Kingston in our urban area. And so they said they wanted it hosted in their communities. So the implications of this, so the education session, it was effective at increasing people's knowledge of trauma-informed care. And people said that it will help them to create environments that are more people-centered, holistic, and empathetic. We got some participant feedback, which will be incorporated into future sessions, including hosting sessions more rurally. We do have 2 education sessions that will be hosted in 2025, including one that is being planned right now as we speak. And we'll also continue to develop this strategy for educating primary care providers across our entire region on delivering trauma-informed care. So that's everything, and that's the contact information for all of our partners and also for myself and Mary as well. Thanks, everybody.
Thank you so much, Ellen and Mary. Wonderful. Is there a question? Yeah, there's a question, yeah. 2 questions, actually.
Hello, thank you for the presentation. I was just wondering if you have any results regarding whether that approach to care changes the dynamics between the teams as well. If it's like larger primary care settings.
No, we haven't collected data on that, but it's a very interesting question and would definitely be worth following up on, especially now that it's been some time elapsed since the last session. It might be good to do a follow-up, but yeah, thank you
because
for that.
I think it's quite, I mean, it applies for healthcare professionals as well. You'd have more understanding towards all sorts of behaviors.
And absolutely, that's what we found. Like originally our idea was, who really needs to learn this are the MDs and the NPs. And actually there was a significant number of other staff that attended the session and really enjoyed it and benefited from it, including medical secretaries, RPNs, dietitians, but because all of these frontline people are interacting with the patients on a regular basis and sometimes having to manage behaviors and develop understanding of why people are presenting the way they are. And so it's an excellent point of how has it changed across the team. Thank you.
Yeah, thank you so much.
Well, yes, definitely. I mean, I think we think of refugees with the, trauma is associated with being a refugee. What I would say, though, is it's often, refugees would come to mind as people who have experienced trauma, but the findings of the ACE study were that actually all kinds of people have had adverse childhood experiences. Mm-hmm. Oh, absolutely. And I actually think of it like universal precautions. Like this is the approach of choice for all people. That this is, in my opinion, and that's what I said was so transformative about it, is it changed my approach to every patient in every scenario all of the time. Mm-hmm.
Okay, one last question for Ellen. The training, the participants in the training for trauma-informed care, did they felt prepared to provide it?
I don't know if we exactly asked that specific question, but it was more about what's your knowledge of it? Do you feel like it enhanced your knowledge? And then asking people what are specific strategies you're going to take away from this. But I don't know if we specifically asked that question. Do you feel ready to provide trauma-informed care?
And what do you think?
What do I think?
Yeah, they would have answered.
I mean, I think based on the knowledge increase that we saw and how many people felt that it increased their knowledge, I think people would say yes. But I think that there's definitely need for some kind of feedback mechanism, though, and kind of someone sort of guiding providers and also like clinics on, okay, how are you doing? How are you feeling in this? Because I do think if it's a new approach for people, they do need support in providing it. Yeah.
Okay, thank you very much.
Thanks.
Last but not least, Maria, you're welcome. You introduce yourself also, isn't it?
Good afternoon, everyone. I'm Maria Tassoni from the University Health Network and the University of Toronto in Toronto. And I'm delighted to be sharing what I will call a distillation of 15 years of work in a leadership program for which I'm a co-lead, a faculty member, and a facilitator into the next 10 minutes. And really, my hope is that you might find a new insight, perhaps a new learning, or something that you might take away to think about your own leadership practice and the collective capacity building we are all doing from a leadership development perspective. So I'm going to use the 15-year case study of our Collaborative Change Leadership Program that runs as a collaboration between the large urban hospital where I work and the University of Toronto. And what I would argue is that this last 15 years has given us a lot to think about in terms of what we need to build into leadership development, in terms of strengthening leadership towards more integrated and sustainable care. I also want to acknowledge my co-faculty members, Sasha, Catherine, Jill, Belinda, and Brian, because this is all of our collective work. So I wanted to start with the purpose of the Collaborative Change Leadership, or the CCL program. And you can see here that the aim of the program, and this is quite intentional in terms of where we put our stake in the ground, is really not just around transformation of the healthcare systems and health professions, education systems in which we work, but also transformation of the people who are participants in the program towards that focus on equity and justice. And this purpose statement for the program has evolved over time, from one 15 years ago that was much more rooted in specific organizations that were either healthcare or universities and colleges, to a more explicit focus on social accountability as that became more present, and just over the last 3 years, that much more intentional focus on equity and justice. And I'll come back to what difference has that made to us. If you take nothing else away around resetting leadership and thinking about how we conduct ourselves in the field of leadership development, one of the most important and probably the most important success factor for the program has been this idea of aligning purpose, which is why I started with the purpose, but also the content design and delivery of the program. We've heard a lot over the last 3 days about shifting mindsets. And I wanted to add to that that this program's really about shifting heart sets, mindsets, and skill sets. So the first thing I wanted to talk about is how content can be an enabler of transformation at that personal, team, organizational, and system level. And this is my first time at this conference, so I've been thinking and listening very carefully about what are some of the threads that I might pull out in this presentation that we've been hearing about in this conference from a content point of view. And the first one that I've heard is really building on our humanity as people. And so in the CCL program, we talk about the transformation journey being one as a dance between the being and doing of leadership. And what do we mean by that? And I love this quote from Otto Scharmer at MIT, that two leaders in the same circumstances doing the same things can bring about completely different outcomes depending on the inner place from which each operates. And so this idea of who we are, what we bring in terms of our passions, our experience, our humanity can be the most powerful instrument of change. And so the program is very much rooted at its core on deepening and expanding self-awareness. And so one of the premises of the program is that leadership development is personal development. Now, the participants might not know that coming in, but it's certainly one of the most powerful takeaways for them as they become alumni. Personal transformation, certainly in their workplaces, but also in their whole lives. We've heard at this conference the concept and the content area that's built in our program around diversity, inclusion, and equity. And we approach this in two different ways. It's a lens that's brought into every single aspect of the program, but we also have specific content in this area. And so we take participants through an exploration around issues related to bias, to privilege, to power, as well as cultural humility and cultural safety. We also introduce, as part of the anchor for the program, and we heard this, I think, on day one in a series of presentations, the idea of complexity. I know I was trained, my son recently did a business degree, he was trained to think about change as something that is linear, and that's in the 2020s. And so in complexity and in our program, We ensured that participants can feel really comfortable with the idea of uncertainty, that no one leader has the answer, that part of being a collaborative change leader is about letting go of having all the answers, that change can happen from any point in the system, and that when we introduce a change within one part of the system, it will have ripple effects everywhere else that may be seen or may be unseen. And part of our job as leaders is to uncover both those anticipated and unintended impacts. One of the core approaches in the program is appreciative inquiry, and I got to hear several great presentations about this strengths-based method. At the core of appreciative inquiry is the idea that the way we ask questions, how we talk, frame our work, and tell stories really affects what we not only believe to be true, but also how we act as people, as leaders, and what change is possible. One of the principles that I love that's based in appreciative inquiry is this idea that words create worlds, and so can our images and our metaphors and our stories. It's not just about strengths-based organizations and systems. We do spend some time, and I've heard this throughout the conference as well, the idea of understanding our own strengths as people, as leaders, but not necessarily focusing on our own strengths and feeling like we need to be well-rounded, as Rath and Conchi say, by mitigating perhaps what some people might call weaknesses, but thinking about how teams can be well-rounded and how they have diverse strengths that can come together in any situation. This is the collaborative change leadership model. And so I just want to orient you to it. You can see at the core, I talked about self-awareness being there. And we've heard a ton on co-creation during the course of this conference. One of the ways through the expansion of our purpose is that we're pushing the boundaries of co-creation beyond co-creating with colleagues, with patients, with clients, with citizens, and thinking more about the voices of the planet and the voices of future generations as we think about our change work. In orange are some of the CCL core concepts that I haven't heard so much about in the conference. And so perhaps this might give you a little bit of thinking or some takeaways to think about how you might build some of this into your own leadership practice or leadership development work. The idea of mindfulness, while more mainstream, thinking about how we pay attention in the present moment, sensing how we use not only our 5 senses, but beyond those in terms of our unique ways of knowing, and how we actually know through things like silence. Emergence, paying attention to things that pop up, because change can be planned, but new knowledge will emerge that makes us think about what are we learning and how do we need to adapt. And generativity, which is really about the art and the science of asking possibilities-oriented questions, in contrast to the problem-solving method I was certainly trained and socialized in as a clinician. And lastly, developmental evaluation. We've heard a lot about evaluation over the course of the conference. I would add this utilization-focused approach, which we've certainly used to look at the impact of the CCL program, and it's one rooted in adaptation and learning. And so this idea, again, that we pause as we're enacting change to think about, great, we've put something out there in the system. What are we learning that was both intended and not? And how do we adapt in these complex systems where this adaptation should be normalized? Now, the power of the model is not in its individual parts. The power is really how individual participants, alumni, all of us integrate these core concepts uniquely as collaborative change leaders. So that was the content piece. I also wanted to talk about the design of the program also as an enabler of transformation. And we believe as faculty and facilitators that transformation is an invitation. We can certainly think about all of the conditions by which we set up a learning community where people can feel vulnerable to share, where they can bring in a learner mindset and that relentless curiosity as we learn more about ourselves and our colleagues. This also is an invitation to faculty and facilitators to really position themselves as integrated members of the learning community. And so we're all invited into the transformation journey. You just can't make it happen as faculty and facilitators. What we do try and do is increase people's comfort with the idea of discomfort, or as Mesro talks about, the disorienting dilemma, where we not just learn but unlearn some of our biases and perspectives and really change the way we're able to be and see in the world as new knowledge becomes apparent and as new opinions are brought to conversations by our colleagues. Some of the other elements of the design of the program, just good pedagogy, include things like group learning, not just reflection, but critical reflection, as well as the use of the arts, and many of these I'm sure you are using in your own educational programs. A little bit more on the design of the program. We're often asked, can you take this program and just deliver it in a workshop over half a day or 3 days? And what we've learned over 15 years and 3 large-scale systematic evaluations is that you do need to give that transformation journey time. And so it is a 10-month program with 5 2-day intensives and intersessions. People participate in teams so that there is more likelihood that the knowledge and skills and change of heart sets and mindsets actually sticks back in their organizations because they have a peer group, as well as bringing in that diversity of perspectives, because we do encourage participation in interprofessional teams. They come with a capstone and specific sponsorship from their organization, and sponsors are engaged throughout the course of the program, and there is coaching built in both by faculty and by each other, peers within the community. So a little bit on reach. So over the course of the last 15 years in this institute-like model, our cohorts are about 20 to 25. We've been able to reach 300 alumni who are now part of an alumni network as of last month. 119 initiatives across a broad range of model of care designs, new educational and healthcare strategies, new scopes of practice that have been implemented across 58 organizations, mainly in North America, but in a number of countries in Europe and in Australia. I wanted to leave you with a couple of quotes from our participants. I am a different person, and because I show up differently, I am seeing different responses to my interactions from one alum, and I simply cannot lead any other way now that I've been part of this program. So with that, I will leave you with some references, and feel free to get in touch either through our website or you can personally reach out. Thanks so much.
Thank you very much for such a great story. Are there any questions? Have a question? Yeah.
Yes, you can only put so much into 10 minutes. I think next time I'll submit an impact abstract. Yes, so we have looked at impact. Maybe the short answer is that we have seen impact at a personal level, at a team level in terms of building cohesion, trust among teams, at an organizational level with the changes, for some examples, in changes in policies, practices around recruitment and retention, and the introduction of new models of care. A number of the teams have published papers on their own capstone initiatives, and we've also published some of our own work. So happy to chat more. Thank you.
Okay, one last question. Of course, you have to follow the program, but if you do not follow the program, where can you start tomorrow or today? Each one of us.
Like if you can't be participants in the program.
Yeah.
Yeah, and I think that's where I started, is my hope that you can take at least one thing away. I would say a place to start is something I've already mentioned, which is we as individual human beings are our greatest instruments of change. And so that focus on really unearthing our own biases, assumptions, deepening our own self-awareness and what we bring to interactions in our organizations is a great place to start.
Oh, wonderful. Thank you so much.
Thank you.
Okay. Thank you so much for attending this, this session, Strengthening Leadership, Workforce Capacity in Integrated Care. We have a small break, and at 3 o'clock already, at 3 o'clock, we have a new session here, and you're all invited. It's a session on social networks, community-based care approaches. Okay, thank you very much. what you want. I suggest you all sit down, and it's the last session in this main room, this main auditorium. Come down and sit down. Be welcome, feel welcome. Wonderful if the doors can be closed. There are not so many people anymore. But the people who are here are very, very interested. So that's very important. So we was a small group in a large space, but it is very, very interested. But because, and of you are very interested, because this is social networks, community-based care approaches. The last session. My name is Roelof Ettema. I'm a professor at the University of Applied Science Utrecht, head of the research group Personalized Integrated Care. We also have a Master Integrated Care Design course and a Postmaster Leadership in Complex Interventions. What I would ask, or what I would suggest is we have 3 speakers, and after each talk we have some time for some questions. And we give some space to everybody. And you're the first one, and I want you to ask you, Dominica, will you introduce yourself? And here is the remote control. Good luck.
Thank you very much. Good afternoon, everyone. I have a great pleasure to kick off the final session of the 25th International Conference on Integrated Care here in Lisbon. My name is Dominica, and I'm speaking on behalf of a team of people, my colleagues, my friends, Dr. Onya Kearns, Dr. Georgina Harnett, and Dr. Michael Hall, and a team of people who are working in Care Cancer Support Group Healthy Transport that I want to acknowledge as well. So today I'm going to talk about transport in the context of integrated care, which is something that we don't often think about. Transportation isn't just a logistical issue. It is a social determinant of health. It means that it can either help people access care that they need or act as a barrier. And in rural areas where specialized healthcare is often far away, patients are forced to travel long distances just to get basic or life-saving treatments. And these travel demands lead to delays in care, missed appointments, and poorer outcomes. And that's something we would like to change. So that's why transport needs to be seen as part of healthcare planning, not as an afterthought. And coordinated delivery of services must take geography and transport into account if we are serious about equity and access. Okay, apologies. Okay, so in the context of cancer, what is the literature saying? Well, the findings are pretty straightforward and quite consistent across the literature. Living in a rural area can mean the differences between receiving recommended cancer treatment or not. So treatment like radiotherapy require daily sessions over several weeks, which can be especially hard for people who are living in rural areas. One study showed the average rural breast cancer patients travel over 2,000 miles and spend nearly 50 hours to just get to the treatment. And research shows that longer travel distance are linked to missing appointments, worse survival outcomes, and higher psychological distress. And this is not just for the patients, it's also for the families, for their carers, for their loved ones, who also face often financial burden and also emotional strain. And these are not problems that can be solved by simply trying harder. They need system-level solutions. So now I'm going to move on to talk to you about, to introduce you to the Care Cancer Support Group service and the service evaluation that I had the pleasure to lead this year. And just in, I guess to give you some context, County Kerry is a rural area in the southwest of Ireland, and that's where I live and work. And the Care Cancer Support Group Health Link Transport is a community-based charity. It was established to meet a vital need, essentially to provide people in Kerry who have cancer with transport so they can easily get to their treatment. The Kerry Cancer Support Group works in partnership with organizations such as our National Health Service Executive, the Irish Cancer Society, and other services. And beyond transport, the organization also delivers Reduce Your Risk programs to schools and community groups, showing that its mission is also about prevention and education. On the right side of the slide, you see the map of the new integrated health regions, which were introduced in Ireland just in March 2025. So you see Kerry, which is on the left in green. So people from Kerry have to travel to Cork, the whole area in green, but also to Limerick in pink, and as far as Galway. So the treatment, the main treatment hospitals and facilities are spread across the county. So what is involved in the service that I'm telling you about? Well, the first thing that really struck me was that this service is designed to be as inclusive and supportive as possible. It is open to everyone. Any adult who has cancer who calls to say that they need transport will get accepted. So I guess the referral system is very, very open, and it reduces barriers and delays. Support is provided at every stage of the journey, before, during, and after. And really there is a very, very strong emphasis on privacy and confidentiality. There is also close collaboration with local hospitals, which creates a mutually beneficial arrangements or solutions. And I'm going to give you some examples later on. The Blankets of Hope initiative is something that is very, very special and beautiful when you think about starting the journey with the service. So every person gets a little gift when they get on the bus for the first time, and that gift includes a large-sized blanket. And those blankets are knitted by people in the community, and that kind of shows that this service goes beyond the basic logistics of the transport. It's about care and community connection as well. So there is many day services across the County Kerry which are participating in this initiative, which gives people a sense of connection and something really important to do. In terms of resources, the service is made possible by a dedicated team of people. There's one manager, one admin person, 7 paid drivers. There is 11 volunteer drivers at the moment and 5 volunteer companions. And the service has 3 vehicles, one larger bus, which is a 33-seater, one 8-seat minibus, and then one Jeep. So in relation to evaluation, and you all know there is different ways and types of evaluation, this one was a summative evaluation which looked at the data from 2024 and what kind of impact the service had and how the service was implemented. And just in the interest of time, I won't be able to give you all results, but we'll focus on some aspects that are relevant to integrated care. We drew on the 2 main sources of data. We worked with routinely collected data, such as electronic records that service has for the whole 2024 period of time, testimonials, and published service reports. And after that, we concluded interviews with different stakeholders, and we combined data to generate the findings. For the purpose of this presentation, I'm going to give you examples of mapping against the core principles of people-centered and integrated health services, and then relevant sustainable developmental goals as well. So this is a very simple slide, but it is quite meaningful. So when you look at 2024 data, you see that we had 547 active service users, And that includes 271 people who were newly referred to the service in 2024. And approximately half of them are over 70 years of age. So this service really supports what we're trying to do, which is the integration of services for older people. And Ireland is quite proud to be leading that integration internationally. Transport was provided to almost 5,000 appointments for people with cancer from County Kerry. And what's interesting as well, if you look at the gender spread, it's almost equal. And we do know that sometimes it's harder for male population to attend for their treatment for particular types of cancer. So again, this service is very inclusive that way. So when we look at the core principles for integrated care, and when we look at SDGs, and we do know that by 2030 we want to see a huge difference in how we are delivering health service and social services as well. So we were able to, very, very quickly, we were able to identify evidence for all 16 core principles guiding people-centered and integrated healthcare services and 3 SDGs. It was not difficult to find the proof that what the service is doing is fully aligned with the principles of integrated care. So I'm just going again, because of the length of this presentation, to present you with mapping for 3 core principles that I've picked for today. And you possibly know them from Ferrer's and Godwin's paper, empowering. So this is about supporting people to manage, but also to take responsibility for their own health. So one of the quotes from a service user, "My family were supportive and had made themselves available to me throughout diagnosis and initial appointments, but I wanted to hold on to my independence. This was very important to me." Then the care that we want to provide needs to be coordinated, which means that it's integrated around people's needs and effectively coordinated across different providers and settings. So this is what I referred on before, how there is agreement between the boss, which I call the care bus, and then the hospitals. So using the service meant that our appointments were tailored to fit in a special morning slot arranged by Kerry Cancer Support Group. We were all seen together and were out as quickly as possible, and on the road home again. I was often home at lunchtime. So you can see the proof how the hospital has facilitated the service, so when people travel together, they actually access treatment together at the same time. And then in terms of the service being holistic, which means that we focus on physical, but also socioeconomic, mental, and emotional wellness. The laugh and the banter to and from our treatment made the weeks pass so quickly. It never felt like we were on a trip to a hospital. The removal of the added layer of stress of getting family and friends to drive was beneficial in itself. In relation to SDGs goals, we've looked at goal 3, which is ensure healthy lives and promote well-being for all at all ages. So I've mentioned to you that approximately 50, it's 51.7, I think, % of population in the service is over 70 years of age. But when I looked at the numbers further on, there was 24 people who were over 85 and several people in the service who are over 90 who get on the bus to travel to treatment. Then goal 11, make cities and human settlements inclusive, safe, resilient, and sustainable. In terms of accessibility, the service provide links transport as well, which means that people who are living in the area that there is no public transport can actually avail of the service as well. And then the goal 13, take urgent action to combat climate change and its impact. And we heard a lot this morning about that. Of course, coordinated transport means that there is less vehicles on the road. So it is serving our planet as well. I hope this will play, because I could be talking about the service, but you need to see this video to understand really what it means.
It is the most amazing service I was ever thought of. Amazing. can sit back and they'll drop you here. Mike will drop you at the door there. You can go to sleep if you want to, and you can, if you want to talk or if you want to have a bit of a laugh. You know, everyone has great our companionship here, really. Like, picked up there at 8:15 in the morning and brought back again and dropped out, and you can sit back and tell yarns and tell lies sometimes and have a good laugh. It's a fantastic service.
Our centre here in Tralee is about the service user, but also about their families. We have rooms here, this room here that you see I'm sitting in, it's our information and support room. We have people come in here. We have a group of volunteers who've been through their cancer journey, and thankfully out to the other side, we call them peer companions. They meet with people who've just been diagnosed and who've been hit with, I suppose we say, like punched in the chest, hit with a sledgehammer. They really don't know where they're going, they're scared. And these people meet them and talk to them in here, and they give them advice, they give them support. They're there at the end of a phone. They go with them sometimes on the bus just to let them know what it's like, to, you know, just that, take them under their wing basically, a companion through their journey. So it's great to have somebody who's already been through it and out the other side.
Okay, at least you got to hear the real Irish accent, because I don't sound Irish. So just to conclude, transport services like Kerry Cancer Support Groups, HealthLink, do much more than just get people to appointments. The data that we have shows the real multi-layered benefits: reduced stress and financial pressure, better treatment focus, and stronger peer support. There are even signs that it improves treatment completion rates. And these services also strengthen community ties. You heard about volunteer drivers and local initiatives like the blankets. And all of that show that how transport becomes a tool for connection. It's not only mobility. So it's really important for policymakers, if there is anyone in the room. This is a call to action. Specialized coordinated transport solutions must be part of integrated health and social care strategies for everyone. And especially in light of today's environmental concerns, group transport isn't just socially smart, it is also ecologically responsible thing to do. Thank you very much. Are there any questions? Thank you.
Thank you, Dominica. Thank you. Is there a question for Dominica? Yeah? Marlo.
So this is a really good question, because when I started doing this evaluation, I was overwhelmed by simplicity of it, that it just makes sense, and how people, especially people in county care, and I know I'm very biased, but people put initiative to practice. But that's what I meant with the last slide, how to bring it to policy level. So my plan is, this evaluation is not finalized yet. The report hasn't been written yet. It's still being finalized. But the hope that I have is to look strategically how we can change it. So hopefully next year, when we talk in Birmingham, I'll have more answer for this. Because I do think that, you know, it's just ticking so many boxes. Yes, it's a very unique initiative in Ireland. We don't have those services in other counties. And then funding is another issue. Yes. So part of this presentation, when I was thinking about it, I said to myself, this is not just about showing this wonderful service. This is to try and change how we think about transport, because this is not about getting from A to B. So this service wouldn't be as unique if it was just being provided in individual cars. So we're talking about people getting on the bus together, going through treatments together, and then sticking to the treatment because of the social aspect. I absolutely agree with that. Thank you. We will. Thank you.
So I have another question. Following this path, does it for other diseases there are also these gaps? There are also needs for transportation.
Yes.
And is that a possibility?
I think there is always a possibility.
Yeah?
Yeah, and there is a need. We spoke about population of people with neurodegenerative conditions because obviously, for example, I did a lot of research in motor neuron where we have center of excellence. We have, there used to be one years ago when I was studying, there is now 3. But of course, as the disease progresses, it's harder to get to appointments if you are mobily so impaired. So absolutely, yes. It's just the uniqueness of cancer, I suppose, and radiotherapy is the frequency of travel and the importance of sticking with the treatment for your outcomes. But yes, absolutely. Yeah. It just makes sense, I suppose, to, again, it's going back to funding and it's going back to commitment from higher up to support those services and scale them.
Yeah, and of course, commitments from society, from the social system.
Yes. Yeah, absolutely. Yeah.
Thank you so much.
Thank you.
Okay, wonderful. Okay, we're going to our next speaker, Reshma. You can come up, and we decided on you are going to introduce yourself. So here's the stage.
Good afternoon, everyone. My name is Reshma Nouri, and I'm a postdoctoral fellow working at Queen's University, Canada. So I'm absolutely delighted to be here to share a research findings on behalf of my team. So the presentation is about the community support providers in the social network of older adults living in naturally occurring retirement communities. So this study is being conducted by a broad interdisciplinary team, and the principal investigators of this study are Dr. Catherine Donnelly and Dr. Vincent DePaul from Queen's University School of Rehabilitation Therapy. So welcome. So I will begin with some statistics, and I'm sure you all know about it. So we know that the world population is increasing rapidly. According to the United Nations Department of Economic and Social Affairs, in 2017, there were 1 billion people who are aged 60 and over. And this number is expected to be more than double, actually. So to 2.1 billion by 2050. So the number would be huge. And we need to be prepared with our support and services so that we can provide appropriate care to older adults. I think we all know, and it was evident during the pandemic, like older adults nowadays, they prefer to stay and live in their house and communities for as long as possible. And of course, there are different models out there that can actually support aging in place. So naturally occurring retirement communities is one of them. So in short form, we call it NORG. So for those who do not know about NORG, it is a geographic area. I would say like a small geographic area with a large proportions of older adults living in that particular area. So sometimes it looks like a group of older adults, they just moved in a neighborhood and decided to age together. So in the past few decades, the prevalence of NORG has also increased rapidly. So I'm just sharing 2 examples from the literature, how it evolves over the time in 2 different countries. So one from Canada. So the Dr. Catherine Donnelly and her team identified the NORG in Ontario, Kingston, in Ontario, Canada. And they have found, like in 2006, there are only 8.7% areas identified as a NORG. And this number has increased to 27.2% in 2021. A similar trend also noticed in Australia. So a group of researchers in Australia also identified NORC, and according to their calculations, in 2011, there were 1.3% statistical area level oil identified as a NORC, and this number increased to 2.1% in 2021. Obviously, there is a significant difference, and you might have questions. I'm happy to answer later. But one contributing factor that actually contributed to the differences in terms of prevalence of NORC between Canada and Australia is the criteria that was used to define the older adult. And we all know that one of the biggest challenges sometimes older adults face in their community is the social isolations and loneliness. So loneliness is the feeling of being alone, and the social isolation is the number of connections. Besides that, they also experience some physical health issues like functional limitations that also impact their day-to-day life. Therefore, it is really important for them to have access to both formal and informal support systems. So informal support, most of the time, it comes from friends, families, and because out of love and loyalty. And the formal support, it mostly comes from a professional. It could be paid, could be unpaid. As of today, in Canadian context, we have limited study that explore actually community support for older adults living in NORC. So I'm particularly talking about the NORC environment. Therefore, the objectives of this study is to understand the types of formal support providers that older adults interact with and the nature of their interactions. As I already mentioned, I'm presenting a small part of a large study that we called OASIS study. So OASIS is a NORC-based program that actually support older adults to age in place, and also it addresses the important social determinants of health, specifically the loneliness and social isolation component. So for the data collection, actually, we conducted a social network analysis using a method proposed by Auditorium. And the way I actually conducted data, you can see on the slide, like we provided a concentric circle to older adults to identify all the people that they consider as part of their social networks. So, and then we asked them to place these people in different circles, and which could range from very close to least close. And then in the original framework that was proposed by Auditorium, she actually proposed 3 layers, but for this study we modified it and added the community support circle in this concentric circle to get an idea about the formal support provider that older adults consider as part of their social network. So once they identified their community, their formal support provider as part of their social network, we asked older adults to complete a detailed questionnaire for each community support providers. And in the detailed questions, actually, basically, we asked about the demographic information of the community support providers, as well as the type of support they actually received from that specific person, and their level of satisfaction with the support and services they received from the community support providers. For the data analysis, we mostly use the descriptive statistics because the study is still ongoing. So it would be very much descriptive, like percentage mainly. So a total of 116 older adults participated in this study. And you can see that in terms of their age range, it was 48 to 92. And a majority of the older adults were women. From this slide and the subsequent slide, it's all about the community support providers. So 116 older adults, altogether they identified 263 community support providers as part of their social network. So on average, individuals actually identified 2.1 community support providers as part of their social network. And I have to acknowledge some limitation of this study because we noticed like we have lots of missing data in different questionnaire. So you can notice like the percentage for the number of population is a little bit different under each section. So it was because of the missing value that we noticed after data collection. So among 263 community support providers, actually older adults identified the gender of 178 community support providers, and majority of the community support providers were female, and the percentage was 61%. In terms of the age categories of the community support providers, so majority of them were between 36 to 55 years old. So when we asked about the older adults, about the professionals of all the community support providers that they identified as part of their networks, so we have seen like a majority of them are family doctors, and the number was 32%. They also identified the spiritual support provider as part of their social network, and also the medical specialist and some other service providers. So when we asked about the type of support they received from their community support providers, and again 48% community support providers actually provided support in relation to their physical health, and this kind of support mostly came from the family physicians or family doctor. And 19% of the community support providers also provided support with their mental health, and this kind of support mainly come from the spiritual leaders. So when we asked about the length of time actually participants have known their community support providers, so 38% community support providers were known to older adults for 1 to 5 years, and 24% of the community support providers are known to 5 to 10 years. And as you can see in the graph on the right-hand side, that most of the participants actually were satisfied or very satisfied with their community support providers. So in conclusion, I would like to say, like in our study findings also confirm what has been written in the literature in other studies, like the critical role of the family doctors play in lives of older adults who are living in the communities. And then the interesting thing, as I said, like almost 9% participants actually indicated like they received the spiritual support from the spiritual leaders. So that is the important findings, and I want to highlight like whoever is interacting with older adults, we need to be mindful like they may have spiritual support needs. So I think that it would be a good idea that to have open discussions with older adults and giving them the opportunity to discuss about it. And if they really express the need for community support, spiritual support, it is worth considering to include those support providers as part of integrated care. Because if the older adults are given the spiritual support, it has both mental and physical outcome, and also it helps them to cope with the stress as well as their loneliness. So when we work with older adults who are living in the naturally occurring retirement communities, it is really important that we offer an integrated service by coordinating different kind of service that interact with these populations. And NORC, as I said, like it is a small geographic area, so it creates a great opportunity for health professionals to offer integrated care in relatively low cost, because it reduces lots of administrative cost because of the high density of older adults living in small geographic locations. So as a future study, we are hoping to investigate how older adults choose a different service provider for various types of support over time. And that's it. Thank you for your attention, and I'm happy to answer any question you may have.
Are there any questions? Yeah, Mardu.
repeat your question? Sorry, what?
Can you repeat it, Marlou? A little bit louder?
At this moment, I'm not sure, to be honest. I have to acknowledge my limitations because I'm a little bit new in studying the healthcare system in Canadian context, so I may not be able to answer you properly. But to the best of my knowledge, at this moment, it's not. But that's why we are proposing, like, okay, it would be helpful, like, if we can also include those support providers as part of the care system. Yeah. Yes, for sure, but again, I'm not sure whether I can answer your questions. Yeah, it would be good to have those kind of skills, but again, if one person cannot provide every single services, so in that case, obviously, we can invite other service providers as well in the circle of care.
And following this, these spiritual leaders, not every person wants a spiritual leader or spiritual support.
That's true.
Yeah.
But
everybody needs a spiritual support. The whole thing is, are you going to ask for it?
yeah, but I also know some people may not need, but more or less, I would say yes, maybe most of the people need spiritual support regardless their belief system, but yeah.
Yeah, because you had some high satisfaction rates. Were the people also not satisfied? Because that was not in the graph.
There is only a small fraction of people are dissatisfied with their service providers.
Yeah, so most of them are very satisfied.
Yes, and maybe that's why they considered them as part of their social network.
Yeah.
Maybe those, I mean, if they are not satisfied with anyone, maybe they didn't include them.
Yeah.
But that is a great question, so I probably have to follow up with our older adults, like, hey, is that the truth? That is my interpretation, am I right here?
Exactly, for future research, yeah, wonderful.
Yes, exactly.
Yeah,
Thank you. Yeah, I haven't thought
other
about
questions?
it.
No? Okay, thank you so much. Then we're going to our last speaker, Jason. And we also agreed upon you are going to introduce yourself. Here's the remote control.
Good afternoon. The last speaker of the whole conference. And I just realized I got the date wrong. I'm actually here as a pinch hitter because this presentation should be done by Brenda, but she's not able to make it. Actually, there are a couple of other people. You can see those famous names on the list there who are far more qualified to speak on it, like Nick Goodwin and Anya and so on, but they are full up, so it came to me. So I hope to do this justice. So, that was my preamble. So, through this conference, we keep hearing a lot of presentations, and they always start off with things like aging population, multimorbidity, rising costs, and so on. I attended my first integrated care conference in 2011. That was the Asian one. 2012, I attended my first international one. In 2013, I was involved in the first World Congress. It's been the same song. We are still singing the same lyrics. So why so, right? Because today, care still remains fragmented, reactive. Through this whole conference, we've been hearing that. COVID-19 made it even worse, and we actually saw the problems. And part of the issue might be that we have always been resorting to structural reforms. Our solution to a lot of things is, there's a gap here, let's fill it. We have a program to do this. And I come from Singapore, and we are very good at finding holes to patch, right? We can have another conversation about this another time, but what happens is that we don't have a system. We have a patchwork of multiple systems and subsystems so that we try to build bridges between silos, and then after that we build bridges between the bridges and the bridges between the bridges, because we are forever trying to fill in the things that have a problem in the system. A lot of it may be because we are not really recognizing the complexity of what we are doing, which is what this presentation is about. So project-based approaches, they often don't scale, they can't sustain, and basically we actually increase the fragmentation. So why do structural reforms fail? Short-term, there are cross-sectional interventions. Most of what we talk about is all about this. And we see this a lot in Singapore because if you want to do something, you need to get approval, you need to get funding for it, you need to put up a case, and they're not going to say, I'm going to do this project and it's going to come out in 10 years' time, this wonderful thing is going to happen. They want 1 year, 2 years, 3 years, right? So we are always limited by the way we operate to having all this, we are always resorting to structural reforms. But because we are doing this and we're not changing the larger system, so if you have a hospital, let's say, with patients who have difficulty going home, there's a big crunch, so we have got medical inpatient care at home. We understand them at home early, look after them at home instead of using our inpatient bed. Well, we create that system, we do that for that one, but we ignore the fact that actually the wards, patients go out, they have to change their processes, the family members have issues, looking after people at home. So we are trying to fix one part of a larger system, one part at a time. And governance issues, because people lose funding, they lose control. We create new silos. Funding rigidity is really interesting because we have got lots of health and social care services historically funded by 2 different ministries. We not only have different funding mechanisms and funding rates, they insist on means testing to make sure that people only get the care that they deserve socioeconomically, but the means testing is different. Thankfully, they have resolved that, but because of all this, the way we approach things, we create a lot of issues by trying to solve problems. So we have an over-reliance on multiplex structural fixes which actually add complexity and they don't solve the underlying problem. An old lady at home doesn't have lunch. What we do, we have got Meals on Wheels to close that. But the fundamental problem is that they are alone during the day. That problem is not being fixed. And then we can't fix the issues of loneliness and aloneness. Right? So if we ignore the fact there are people involved, there's a lot of context, feedback loops, and so on. And so this presentation is about whether we can think about a shift from a paradigm of trying to forever scale pilot projects to how do we enable networks at scale by creating the network, but not by starting small and growing big, but creating an environment. And I will emphasize this again at the end. So here are 2, well, I put bracket radical theories because they're not that radical, but they're actually quite well known. Complex adaptive systems and relational network theory. We work in a very complicated ecology, right? So healthcare is complex, there are multiple actors, they have agency, they make their own decisions. So some of you might have heard already about Healthier SG, our primary care reform. Well, when it was planned and rolled out, the idea was to recruit primary care clinics, to recruit people, do all these things. They didn't plan for doctors not wanting to be part of the program. They knew that might happen, but they weren't planning. They didn't plan for the underground communications on WhatsApp and Telegram about people basically dissing the whole project. And they didn't plan for the whole range of responses, from people who refuse to sign up to people who sign up because the money they think is good. And I've got one primary care friend who told me he signed up. And I said, but he doesn't believe in it. So I said, why don't you don't believe it, but you signed up? He said, yeah, because if I sign up, they keep me informed. Then I know what I don't like. Because if I don't sign up, they don't tell me anything, I don't have the evidence for my disgust. And I thought that was a very clever way of looking at it, but he's not cooperating. So there are multiple actors, unpredictable context. An idea of complex adaptive system is to recognize that there are agencies, there's emergence of new things that would happen, and how to take that in part of our planning. So we want to see how we can create ecosystems that are adaptable, they are self-organizing, and A lot of it is actually echoed by what Antoine was saying yesterday about relationships. It is not about telling people what to do, it's about getting people to have a community that wants to do it. So integrated care actually should be much more relational, contextual, and co-adaptive. Relational network theory, this is where I'm on very thin ice because this is a little bit new to me, integrates the idea of network structure and relational coordination theory to emphasize how people relate and work with each other, looking at goals, mutual respect, trust, and communication. And there are certain attributes that can go to define the kinds of networks that we have, and therefore the approaches to those networks. So, idea here is to create trust, legitimacy, and sustained cooperation. Now, a little bit more about this, and this is, I'll go through quickly, but there are various attributes which is used in this, and you will see that networks are all not the same. Some are big, some are small, dense, non-dense, and there are some key actors and so on. And they will differ along all 6 dimensions by the content that they have, whether they have shared goals or not, they know each other, they respect each other, and so on. So a lot of our programs actually treat people as if they're cogs, right? So I have got a home nursing system, they will go up. Every nurse is supposed to be the same because they do exactly the same thing. Every patient is supposed to be the same. They differ by medical condition. They don't differ by personality. Right? So we factor all of those things out in our effort to create a project that we can present to us for funding. So there's internal and there's external complexity. Basically, this is just a way of framing things. So to see that if you have got different kinds of networks, so for example, a low complexity system where there are limited steps, independent and known actions, that one you don't need to factor too much of the issue of complexity. But multiple independent steps, decision making, complex chronic care, which is what we are talking a lot of it, those are high complexity issues. And that's where relational connections, trust become very important. There's also external. And there depends on how many organizations, right? So we end up with issues with, in Singapore, we've got, there was once an IFIC seminar where somebody asked how many agencies look after health, and I think our answer was about 7, because we have got our pre-hospital care, our social network, social care, social support, they're all under different ministries, different organizations, right? So this is a layout of how the relational network will give you an idea of the kinds of networks that you're working in. But actually, that's not my main message. The main message, okay, after this exemplar, which is the next space of Alice, it's an emerging network model which looks at care, agent care fragmentation, and it's through the Central Coast Health Alliance. There are 3 principles: integrated care delivery, connected communities, and I like this, healthy place making the place people live in healthy naturally, right? And they have got this interesting thing called network link workers and network curators. It's not new. UK started it, more than 10 years ago, 20 years ago. But the key role of these people is much more organic than here's a job, you go do it. So an example is that an elderly couple is supported through this you'll see, many projects will say this, but the key here is that they don't have a phone number to call in case you fall, don't have to call, you call in case you've got dietary questions. What they have is actually a neighbor who's a peer in the network, and this peer, Betty, will step in at the right time. She's the neighbor, she works together. So what they have actually created is not the goal here is not to create good outcomes. The goal here is to create an ecology that naturally leads to good outcomes. Now that's a paradigm shift that we need to think about. Right? They don't have referrals and bureaucracy. Singapore went through a phase where we are trying to consolidate all help calls into one phone number. It was a total paroxysm of the system. In the end, we decided we can't do that because they may know one number to call, but how do you respond with so many different agencies and organizations? So this particular very short example shows you how creating a community of people close to each other, helping each other, are able to do a far better job, because people don't actually try to get a system response when they have a family response. In my family, people have questions to medication. I'm the one who packs the medication for my mother-in-law every week. They don't need to get a home nurse to come do that, because I can do it. Now, if we have a whole society like that, where you got peers, people next door, people down the street, who are able to work together like that, with the help of a professional layer, that is a whole different ecology. So, some key points. If they're highly complex patients, we need to look at, in this kind of dense networks, we need to think in terms of complexity. We need to look at emergency situations that require these centralized high-trust responses. And we need to bring in a lot of these community-based organizations. The structural holes that we are talking about, that we try to fix, they actually highlight the missing links. They don't highlight services that are not there, that we have to create. They're highlighting things that perhaps could be done more naturally within the community. So CAS and R&T gives tools for both diagnostic and design. So some key principles around it. I won't spend too much time because I'm running out. Right. Okay, all right. Thank you. So we have to design for adaptive interventions. Again, come to me after that. I can give you a long list of projects in Singapore where we have a problem, we fix that problem, and we define things around that. So if you fall outside the scope, I'll give you one example. Telemedicine. We say we want to monitor patients at home. So we go to the hospitals has a system where they have a telehealth project. You're given equipment to the patients, they monitor them at home. Then they improve clinically. They don't need to be monitored like that anymore. What happens? They leave the project. So we actually are defining people by the projects that we do. A better illustration of this one was a conversation I had with an endocrinologist who was basically saying, we are patient-centered. I said, how so? Well, look, our diabetics in the community, we classified into 5 different categories. The well, the pre-diabetic, simple, complicated, and end-of-life diabetics. And I had a hard time explaining to her, you're not patient-centered, you're service-centered. Because you divide people into those 5 groups because of the services you give to them. You don't want to do end-of-life advanced care planning for the other people because it's not. You want to concentrate on the people who need it because you have an ACP program that has got KPIs and so on. But the patient, so you're not patient-centered. Patients actually move between groups. Any diagram that shows the patient moving from one point to another is not patient-centered. It is usually service-centered. Right? So we need to look at that. We need to look at relational norms, creating the ecosystem, the ecology that people can naturally look after each other. There obviously needs to be continuous recalibration because this is not going to be one of those things that we can plan out and execute and get there. It's going to be the thing that we have to move it along, get feedback, adjust as we go. Right? And evaluations ought to be around ecosystems, about how well they operate to improve the health of people, not the exact health itself, because that's subject to multiple conditions, other factors. And if we focus on that, we actually work towards getting those numbers to be good, but it's not sustainable because that ecosystem is not naturally trying to improve health. Right? You have been doing it for them. I had a conversation multiple times about KPIs. KPIs that show a program is good, that people benefit from it, are very important. But again, caveat in Singapore, we have a tendency to focus on KPIs that are, did you use up your budget? Did you overrun? Did you enroll the right number of people? And so on. Those are process indicators, which don't tell you how good the program is. It tells you how good the implementer is, because they're able to hit the targets, right? So the conclusion is, after all that, is we need to shift from trying to control the system to creating connections in the system. Complexity is not a problem to eliminate. The reason why we take a situation and we slice it into small little bits and try to fix them one by one is we're trying to cope with complexity. We're not exploiting and leveraging it. We're trying to get rid of it. But It is the fabric of healthcare, it's of human society. We are like that. CAS and R&T frameworks help us to look at it. Ultimately, as I said, we need to build relational ecosystems, not hierarchies and so on. And this is actually not a new idea. We create networks of trust. And well, in Singapore, about 8 years ago, we had a minister who came up with this idea of the 3 beyonds, because he wanted a shift in how Singapore viewed healthcare, health. That is to say, we move beyond hospital into the community, move beyond quality, getting high quality, to getting value for what you're doing. And the third one was moving beyond healthcare to health, right, to a more preventive approach. This is a variant of that 3 not just, and there are 3 paradigm shifts that we need to get away. So not just projects, but patterns within the community of how people work together, relate to each other, and so on. We need to get not just outputs, but relationships that will be self-sustaining. And we need to go beyond not just control, but care systems, right? To look at how people care for each other and not just go after the long-term KPIs. So I started with the preamble. Here's my epilogue. A long time ago, I did this mind map for a spiritual kind of thing. And I did a mind map, and the guy my instructor, just looked at it and told me, I see what you do, I don't see who you are. And that was a profound thought, because everything I put on that mind map was what I did, right? So I think, in a way, the fundamental shift here is not so much to target individual problems and try to go after them, but to think about what kind of society we like to have, what kind of relational ecosystem that we like to have that can naturally take care of the health of each other, and not just, and these days we're talking about mental health, loneliness. It's gone well beyond just health, right? And then we do what we have to do. Yogi Berra always has a very interesting take on this. If we don't know where we want to go, right, we've got to be careful, because we might not get there. But where it's there, we don't really know. And the next line, I said this to Nick a couple of days ago. I said to Antoine yesterday, and they both said they want to take it to use it in some other areas. So I got to put it over here, so that if you ever hear this again, you heard it here first, right? We got to stop being engineers. We stop trying to think of everything as a complicated, massive hospital building project where we can break things into small pieces, each one does your bit, and somehow everything comes together. We have to think ourselves as gardeners, right? You have to put in the manure, do the weeding, everything else, make sure the sun shines, the rain comes, and let it grow. To some extent, we need to resource, direct, and get out of the way so that people can actually get better. Thank you.
Jason, thank you so much for your passionate story, because it's a very, very important issue you make. Yeah. Are there questions for Jason?
Sure.
Yeah. Manu
Of
has
course.
a question. Yeah, no, there's... Yes.
Where did the two become separated? How does it work?
I think that's a bit too existential for me to give you a reply to, but it's a good point. Yeah.
It was just a remark, eh? Victoria, I think Victoria has a remark too. Yeah.
The problem I have now is I've got too many answers for you. One is that society has gotten a lot faster. When I started work in the Ministry of Health, and you were still pre-email, right? Minister asks a question, you send out a letter, it comes back in a week, and I have got a week to wait for the letter to come, the reply to come. Now it's in minutes and seconds, right? So we've gone a lot faster, and we've gotten a lot more stressed, and we are trying to cope a lot harder, which basically means then that which goes to my second point, is that we think less, we read less, and we don't stop and stare at the sky and what's this all for, because we are all busy chasing stuff, right? Yeah, but in a way, it's not our fault, because that's the society. If everyone's running and you don't run, you get left behind. Being left behind is not necessarily a good thing or a bad thing, but it's just that we are just all moving at that pace. And I think the extension to that one is, again, I don't speak for other countries, but we are very busy doing what needs to be done, that we don't stop thinking about why we are doing it. Does it even make sense? So I have had, in various contexts, conversations with people who say they are doing this, and I ask them, why are you doing it? Because minister wants it. Okay, but why does minister want it? And I don't know. And you don't ask, and you don't find out, because if you don't know why he wants it, how are you going to do it? But they will do enough to get through the day. So I think a lot of it is societal evolution and so on. That's my metaphysical answer to you.
Okay, we are going to finish. Yeah. Thank you so much, Jason. Thank you so much. So, some closing remarks. Thank you all for being here. This was the last session, and this was a session on social networks. And I want to conclude with that you're as healthy and happy as your connection to your environment, as your connection to the society. And I want to thank you for attending this conference. I hope you had a wonderful 3 days. I had wonderful 3 days. I'm going home very, very inspired. Safe travels home, and see you back next year in Birmingham. Thank you very much.